Assalamu alaikum, everybody. Can you hear me?
عليكم السلام ورحمة الله.
الله يعطيكم العافية. أهلا بكم. What time do you usually start? At 1 o'clock ولا 1:05 كاتبين?
Yes, 1:05, Victoria, just to give the time for the presenter to prepare the slides.
Oh, okay. Shukran.
Yes, good afternoon, everyone. So today we'll continue with the fundamental of cardiac surgery section. We have 3 lectures today. The first one will be by Dr. Rawan Ghamdi about preoperative evaluation. Will be followed by cardiac anesthesia with Dr. Abir Ghamdi, and third lecture will be about blood products and transfusion by Dr. Amjad. We have 2 guests today, Dr. Huda Ismail, the cardiac surgery consultant at Prince Sultan Military Medical City, and Dr. Fahad Al-Khudairi, who's a cardiac anesthesia consultant from King Fahad Medical City. So I believe we'll start 5 minutes past 1. I think, Dr. Rawan, you can prepare your slides.
Okay. دكتورة هدى السلام عليكم.
وعليكم السلام آيات، كيف حالك؟
كيف حالك؟ طيبة؟
الحمد لله، الله يحفظك ويبارك فيك.
Welcome يا دكتورة. happy صراحة to meet you again.
الله
يسعدك. online يعني.
الله يسعدك حبيبتي، يبارك فيك يا رب.
الله يسعدك
جميعا، الله يوفقكم جميعا.
آمين جميعا.
دكتور روان.
Yes.
تفضل.
Assalamu alaikum. Good afternoon, everyone. My name is Rana Ghamdi, cardiac surgery resident at R1. Inshallah, today I'll be talking about the pre-operative evaluation of cardiac surgery and risk stratification. I will go through the important things that the patient needs to do before cardiac surgery, how to assess him and how to prepare him for surgery, and what's his mortality and morbidity risk and how to estimate it. So why is this important? To identify cardiac and non-cardiac problems that might need to be addressed preoperatively to minimize the post-operative morbidity and mortality. Also, the severity of comorbidities and the patient's quality of life may contraindicate a surgical procedure that otherwise seems to be indicated. So once a patient is considered a candidate for cardiac surgery, a comprehensive evaluation of the patient's overall medical condition should be done. This includes detailed history, physical examination, investigation, and further evaluation and consultations as indicated according to each case. Starting with the history, obtain all the demographic data. If the patient known to have any comorbidities, diabetes, hypertension, renal or liver dysfunction, history of CVA, peripheral vascular disease, or history of bleeding disorder, and obtain details regarding this condition. Is he controlled or not? Is he on medication? And is he compliant on this medication? Also, if he's following regarding this condition. The chief complaint and the analysis of the chief complaint, the duration, the nature, the pattern. We can use the NYHA classification for shortness of breath and the Canadian classification for angina. If the patient has any associated symptoms, palpitation, syncope, neurological symptom, GI or urological symptoms that may require further evaluation. Also, history of any known allergy, history of smoking. If the patient is actively smoking, he should be advised to stop smoking at least 4 weeks before surgery, and it's better if 2 months. Family history of cardiac disease, past surgical history, and medication. Review of medication is important to determine which medication the patient will continue and which he will stop. So this is the 2017 guidelines for preoperative medication in cardiac surgery. Aspirin is beneficial for both primary and secondary prevention of cardiovascular disease. It is routinely given to patients with acute coronary syndrome, as it's shown to reduce the mortality. Patients on aspirin who will undergo a CAPEJ, continuing aspirin in the preoperative period should be considered. Patients who refuse the blood transfusion or undergoing a non-coronary cardiac surgery or at high risk for bleeding, stopping the aspirin at least 5 days before the surgery should be considered. Bridging the oral antiplatelet with low molecular weight heparin is not recommended. Patient on dual antiplatelet therapy who are undergoing elective cardiac surgery, stopping the B2Y12 inhibitors should be considered before surgery. Also, glycoprotein, it is recommended to stop it at least 4 hours before surgery. Patients on warfarin should stop it 5 days before surgery. And you should aim for an INR of less than 1.5 the day of surgery. Patients on NOAC, apixaban, ivarexaban, it should be considered to stop them at least 2 to 4 days before surgery. Preoperative bridging poses a risk for bleeding. Therefore, not all patients on oral anticoagulation should be bridged. Bridging is recommended in patients with mechanical prosthetic heart valve, AFib with moderate to severe mitral stenosis, AFib with a CHA2DS score of more than 4, or acute thrombotic event within the previous 4 weeks, like ischemic stroke, PE, or acute coronary syndrome. Bridging with unfractionated heparin is recommended. Low molecular weight, subcutaneous low molecular weight heparin should be considered as an alternative for the unfractionated heparin. If the patient is bridged on unfractionated heparin, it is recommended to stop it at least 6 hours before surgery. If the patient is bridged on low molecular weight heparin, it is recommended to stop it 24 hours before surgery. It's recommended that oral antidiabetic and long-acting insulin to be stopped the day before surgery. Blood glucose should be routinely checked almost every 4 hours to maintain the blood glucose level between 120 to 180. ACE inhibitors and Rbs should be stopped preoperatively. Why? Because they are associated with reduced systemic vascular resistance and a vasoplegic state during and after cardiopulmonary bypass. Also, they are associated with a higher mortality rate, increase the need for inotropic support, more atrial fibrillation, and post-operative acute kidney injury. In patients with preoperative uncontrolled hypertension, switching the long-acting ACE inhibitor or Rbs to short-acting should be considered. Beta blocker, it's considered to continue before surgery. It is not recommended to initiate statin before cardiac surgery, but patients who are already on statin, continuing it preoperatively should be considered. Moving to the physical examination, obtain the vital signs, the height and weight of the patient, the general appearance and the mental status. If the patient has carotid bruit, this is a marker of carotid disease, which is present in about 10 to 15% of patients with coronary artery disease. Of course, full cardiovascular, respiratory, and GI examination, examine all the lower limb pulses. The previous part of the lecture, the history and the physical examination, is extremely important because this is the part where you build your investigations on. So starting with the laboratory, CBC, check the hemoglobin, the WYC, if it's significantly elevated, this might be associated with an infectious process that need to be identified before surgery. Of course, check the platelet count. The UNE, check the creatinine and electrolyte and make sure they're within the normal range. Renal dysfunction is one of the predictors for post-operative mortality and morbidity. Liver function test, abnormalities suggestive of hepatitis or liver cirrhosis may require further evaluation to look for the cause. Also, as a baseline, most of the patients are placed on pre- and post-operative statin. The coagulation profile, the lipid profile, the thyroid function test. Hyper or hypothyroidism may require the patient to be treated before going to surgery, as it's associated with a high risk for mortality. Also, patients on amiodarone. Amiodarone is an iodine-rich compound that can have a variety of effects on the thyroid function, producing either hypothyroidism or thyrotoxicosis in about 15% of patients receiving it. Blood glucose and hemoglobin A1C to know whether the patient is controlled or not. Optimal preoperative glycemic control is less than 6.5. The higher it is, the higher the risk for complications. MRSA, patients who test positive for MRSA will require treatment with nasal Bactroban twice daily for 5 to 7 days, plus chlorhexidine bath weekly. They should be treated to decrease the risk for infection and reduce the hospital stay. Serology, hepatitis B, hepatitis C, and HIV, and cross and match. Chest X-ray to rule out any active infection that might need to be treated before the surgery. Also, aortic calcification can be seen on the chest X-ray. ECG as a baseline and to look for ischemia and or arrhythmia. Additional images as indicated according to each patient. Coronary angio, echo, to look for and diagnose the pathology. Carotid Doppler if carotid disease is suspected, especially in patients with high-risk characteristic. Patients 65 years or older, presence of carotid bruit, any prior cerebrovascular disease, or patient with left main disease, because of the high risk for these patients to develop a post-operative stroke. Cardiac CT to look for aortic calcification, especially in elderlies. In redo cardiac surgery to measure the distance between the sternum and the right ventricle and aorta to avoid injury, or for preoperative assessment for TAVI. CT abdomen and pelvis also in preoperative assessment in TAVI to assess for peripheral vascular axis to see, including the diameter, the presence of calcification, the tortuosity, and the angulation. CT brain in patient with history of stroke. Dental clearance before cardiac surgery replacement, a valve replacement is necessary to check for and eliminate any present or potential source of infection, which may enter the bloodstream and travel to the surgery site, causing subsequent complications such as infective endocarditis, which is a potentially life-threatening. Dental clearance is not indicated in all patients. The indication for preoperative clearance should depend on the individual situation of the patient. Is he in stable or unstable condition? Does the patient need a coronary or valvular surgery? And does he have a critical lesion, such as left main disease or critical aortic stenosis? Anesthesia should see the patient and take full detailed history and examination, assess for risk factors of post-operative complication, and to give the patient a general idea. For example, regarding the issue related to sedation, the anesthetic medication, the monitoring line, and the awakening from the anesthesia. These are the most important things that must be explained to the patient prior to signing the consent. The patient should be aware of his diagnosis and condition, the procedure, what is the procedure, how long it will take, what are the complications, and the post-operative phase, what will happen. Is he gonna stay in the ICU and for how many days, when he will be weaned off from ventilation, is he gonna wake up with the tube in his throat, and when to be transferred to the ward. Providing patient with information booklets related to their condition and the procedure they will do can help in relieving the anxiety and fear for undergoing an open heart surgery. Preoperative orders and checklist. Checklist in general can make things easier and saves time. So once the patient has been accepted and scheduled for surgery, orders should be written to address the patient general and specific condition. A standardized checklist are helpful, and it can be individualized as necessary. So this checklist is upon admission, where to admit the patient, what is the procedure, what are the lab and images that need to be requested to obtain the vital signs, the height and weight of the patient, the medication, what to start and what to stop. This checklist for the day before surgery, what is the planned operation, what's the indication for surgery, brief summary for the case, what are the lab results, the anesthesia note, and if he has any recommendations or orders, check for the availability of blood, and preoperative orders, which include to keep the patient MBO after midnight, chlorhexidine bath, clipping or shaving the surgical site. Finally, risk stratification. This is an important element of the preoperative preparation for cardiac surgery. It can give an estimation of the mortality and morbidity rate based on the assessment of 4 important categories of risk factors. The first category is the patient demographic, the age, the gender, the race. The second one is the patient-related comorbidities that can have a significant impact on the patient's ability to recover from surgery. In fact, in most patients, mortality and complications are related to a pre-existing comorbidity, such as diabetes, renal or liver dysfunction, cerebrovascular disease, or COPD. The third category is the cardiac disease and the procedure-related factors. The clinical presentation, stable versus acute coronary syndrome. Is the patient in heart failure? The nature and extent of the cardiac disease. Is it isolated coronary artery disease, or is it associated with valve disease? And the degree of ventricular dysfunction. Finally, the preoperative state. Is it an emergency surgery? Is the patient in cardiogenic shock? Does he require inotrope or balloon, intra-aortic balloon? Is it a reoperation? So there are different modalities to estimate the mortality and morbidity risk. We have the STC, the Euroscore, and the Barsonate. This is the STS, sorry. It asks many questions that include the previous categories that I just mentioned. After you fill all the, you answer all the questions, they give you the risk as it's shown here. The risk for mortality, the risk for renal failure, for stroke, for prolonged ventilation, the risk for infection, and the length of stay. Also, the Euroscore, it's another modality that gives you the mortality risk. Same thing, you answer all the questions, and then it gives you the risk, the mortality risk down here. Barsonate is another way to estimate the mortality. After you calculate the score, you interpretate the result. You interpretate the result here. These were my references. Thank you. Any questions?
Thank you very much, Dr. Rawan. Excellent presentation. From your review, when you review the preoperative assessment of patients, what's your take-home message for your colleagues?
Although it sounds easy, the history part and the physical examination, but it's the cornerstone for the assessment of the patient. Everything is built on these two, the history and physical exam. So I think this is the important part that we should emphasize on and focus when we see the patient.
I agree with you. We do miss a lot, and we usually focus more on diagnostic things like echo, angios, and we do really forget that history will give you and guide you to the diagnosis. And I'm really happy that you emphasize that very much, and this is something we are lacking in our current practice also. So past history of patients, family history, these are very important things. The medication the patient takes, these are important things. And the art of taking history is really I think it's a lost art. And I'm really happy that you emphasize that very well.
Thank you.
Yeah. So you were talking about the risk stratification and using scores, the Euroscore, the STS score, the Barsonate score. Did you come across any comparison between these scores? Why do we have so many scores? Why can't we have just one for everything from your reading?
I'm not sure.
Yeah, your colleagues can help you. Anybody?
Yes, actually we have a lot of scores because historically there has been many attempts to risk classify these patients in different places in the world. So for example, the Barsonate was one of the first assessment scores, and it is not really applicable to our patients in this era, because at the time that it was made, the risk of cardiac surgery was a little bit higher because of the because of the less experience in the field and the older techniques and those things. So Barsonate is not used those days because it overestimates the risk.
Yes.
Yeah, the STS score is the American score, which is the most validated score, and it is different from the Euroscore in terms of morbidity, because it doesn't just estimate the mortality. The Euroscore is a good one for cabbages rather than valve procedure, because it's been said that when they validate it with cabbage and valve procedure, they noticed that it overestimates the risk of valve procedure compared to the STS score. Yeah.
Exactly. And the other thing which is very important that you stated also, Dr. Murtada, is that these risk scores are done in patients who are not our patients. You know, they're Western patients. So for us, you don't know, but some of these risks, they can overestimate, they can underestimate. So hopefully in the future, when we have enough data from our society, we can have our own risk scores. But I think what you said, I agree 100% to what you just said. Okay. Thank you, Dr. Murtada.
Most welcome.
Okay. All right. Any other questions? Any for Dr. Rawan?
So, Dr. Huda, what do you recommend to use as a score at the time being?
Yeah, I think we should use both. The STS score, because as stated by Dr. Murtada, it doesn't only include mortality. It includes also the morbidity, you know, prolonged hospital stay, prolonged ventilation, renal failure, you know that. So it gives you even more information. And also it involves valves, which doesn't involve in the Euroscore. Euroscore actually, you just talk about symptoms and the pulmonary pressure and the ejection fraction and just tell you procedure one or combined, while the STS is more detailed. So Anna, for me, I think the STS is better, but it depends on the institute itself. For us in our institute, we use both, because the Euroscore overestimates mortality actually. So you can use both. And as you know, it's very easy and you can calculate it quickly. And when you're talking to the patient, you can tell him you have that risk of, if you use the STS, you can tell him the risk of renal failure, the risk of prolonged ventilation, the risk of in-hospital stay, ICUs, all these kind of risks, and infection, more than the Euroscore. Euroscore will just tell him about mortality. You cannot give him more information. So I think STS is a better score when you are consenting your patient and you're talking to the patient.
Don't you think, Dr. Huda, that frailty index is better?
Frailty index, yes. Thank you for raising that point. Frailty index came actually because of the TAVI, and it's become very helpful. Frailty index, you can use it. It can be used, but you cannot use it for every patient. In our general patients, you cannot use it. I don't think so, in my opinion. You use it, but you can use it when you think this patient needs another procedure. He's not fit for cardiac surgery. So frailty became more recognized because of the age of TAVI, which I think it's something you need to use also, but it's not part of your everyday use. For every patient, you have to do a STS score and Euroscore, but frailty is for specific patients. It's not something you can generalize. But I think your point of view is well taken. And I think usually it's used for patients that you think will not require cardiac surgery or high risk for surgery. So you want to add and tell them, please do another procedure or percutaneous. So this is where we use frailty.
Okay.
Yeah, so it's an additive score, but it's not something you use for every patient, no. Any other questions? Okay, thank you.
Dr. Huda?
Yes?
Yeah, what about dental clearance from your opinion? Do you think that all patients should be seen by a dentist beforehand, or just you will assess them like the day before surgery?
Yeah, really, as you know, in the guidelines, there is nothing about dental clearance. This was done a long time ago because all these guidelines come from the Western society, as you know. So for us, as Rawan stated, that specific cases, you don't do dental, even if they have the bad teeth, you don't do dental, which is severe aortic stenosis and left main. As you know, stress. We have patients who are arrested on the dental couch, actually. The thing is, you look at the patient and you look at the procedure itself. There are some patients who have very bad teeth and the procedure is an elective and they can wait. What happens is that we have the dental, it will take a long time for some of them because the dental hygiene is very poor, unfortunately, in our society. And the infective endocarditis rate is higher than other people and other countries, actually. So I think this is something individualized. You individualize your patient. You can look at the patient in the clinic and you see the teeth of the patient. You ask the patient, and it's part of the physical examination is looking at the teeth. And usually we do that for valve patients. And it's not mandatory for every patient. No, I don't think so. We have also ischemic patient, like ischemic mitral. We do not do dental clearance for them. Okay, so it depends on the type of disease the patient has. Left main, aortic stenosis, these are contraindicated. If the patient has very bad teeth with abscesses, of course you need to do them. And the patient's condition. If it's an emergency, you will not do it. So elective, so it's something you have, it's clinical sense. So I cannot recommend for every single patient, but I can tell you the ones we should not do. Does that answer your question, Dictor?
Yes, clear. Thank you.
Okay, thank you.
So any other comment or question for Dr. Rawan or Dr. Huda?
Maybe I can add on the comment made by Dr. Ayat regarding frailty. So the frailty index is part of 4 sections in the risk assessment for valve patients stated in the 2014 American guidelines for valve disease. So the 4 sections were STS score and frailty score and organ dysfunction and procedural aspects, specific procedural aspect. Actually, if you have any one of those sections fitting in the high risk group, you will consider the patient as a high risk patient. Even in patient with low STS score, if this patient has, for example, high risk of frailty, or high risk surgical aspect, like redo with a patent lima, you will consider this patient as a high risk, regardless of his STS score.
And one more thing, Murtada, major organ dysfunction.
Yeah, I mentioned the 4 sections. One of them is the organs. Yeah.
The different thing is, as I stated, that frailty is just one thing. So when you usually use the word the frailty score, as I said, because it's a high risk patient, but also these patients will not withstand the surgery. They will have complication post-op. So the frailty is not for every single patient, but it's for patients that you need to avoid cardiac surgery, that, bypass surgery, the regular surgery. So I do agree that frailty should be done in patients that you think they are high risk for cardiac surgery, and you want to have an alternative type of intervention. And we are using it more because of the percutaneous intervention, which is becoming more popular now. And thank you, Dr. Murtada, for your interaction. Thank you.
Most welcome.
I believe we are ahead of the schedule, so just give me a few minutes to contact Dr. Fahad if he will be able to join us for the second lecture. So Dr. Fahad will join us in 10 minutes to start the second lecture.
Assalamu alaikum.
وعليكم السلام ورحمة الله وبركاته.
السلام ورحمة الله وبركاته.
Can you hear me very well?
Yes.
أيوة نعم يا دكتور.
Okay.
So I believe we can start with the second lecture. I would like to welcome Dr. Fahad Al-Khdairi, who's a consultant cardiac anesthesia from King Fahad Medical City. Thank you, Dr. Fahad, for joining us.
Thank you for giving me the invitation to have the pleasure to give this lecture. So we're going to discuss some introduction to the cardiac anesthesia today. My name is Fahad Al-Khdairi, and I'm a consultant cardiac anesthesiologist working in King Fahad Medical City. So our objectives for today, we're going to discuss and talk about heparin and the alternatives. We're going to talk about heparin resistance and induced thrombocytopenia. We're going to touch base with protamine. We're going to talk about the special cardiac lesion and hemodynamic goals. And I'm going to mention the special story about the communication between the cardiac surgeon and the anesthesiologist. So let's go. Let's start with heparin. So heparin is the preferred agent for anticoagulation and cardiac surgery. And we are talking about the unfractionated heparin. The heparin usually is physiologically resides in the mast cells and commercially available in two forms. The first form, it comes from the lungs of the cattle, which is the bovine lung heparin. The other one is from the intestine of the pigs, which is porcine mucosal heparin. Unfractionated heparin is a heterogeneous mixture of water-soluble polysaccharides. And usually it comes with different mean molecular weights, but the average is 15,000 Daltons. And it comes as well in in different units as well. So it starts with 5 units up to 35 polysaccharide units. And we need to keep an attention for the units because we're going to know the importance later on. So usually it comes from 5 to 35 units. Heparin is a strong acid, which is negatively charged at the physiological body pH. Does anyone know what's the mechanism of action of unfractionated heparin? So this lecture is interactive, so I need to listen from you guys too. Any volunteers?
Interfere with factor 10.
Okay. Any other answers?
It activates antithrombin factor.
Okay, that's nice. So it binds to antithrombin 3. This is the direct bound. And once the heparin is bound to antithrombin 3, it increases the speed of reaction between the antithrombin 3 and several activated factors. And the most two important factors that we're going to focus on is factor 2 and factor 10. And there is some other factors as well. So the onset of the heparin, so when it's given intravascularly, it's immediate onset. And the half-life usually it lasts for 2.5 hours at the usual cardiac surgery dose. The elimination of heparin is get eliminated by kidneys or it gets metabolized by the reticular endothelial system. The side effects of one bolus of unfractionated heparin, which is we see it every day in OR as an anesthesiologist, it decreases the systemic vascular resistance and drops the blood pressure, which is transient. The other side effect of heparin, the heparin-induced thrombocytopenia, and we're going to talk about this later, and usually this is a post-op side effect. And anaphylaxis as well can occur, but it's very, very rare with heparin. So this is important figure to understand how the heparin is working, okay? So if we can see here, this is the heparin molecule. Can you see, you can see my mouse, isn't it, as a marker?
Yes.
Okay, so yeah, so this is the heparin molecule. And as we said, it comes in different units. So here it's like almost 18 units. And this is another heparin molecule, which is 13 units, okay? So we said for heparin, we need the heparin just to interact with the antithrombin, isn't it? So do you see this dark green bound of the heparin? This is the important bound that it just get bound to antithrombin. So the binding of the antithrombin to heparin requires a critical pentasaccharide sequences, which is dark green here. So for heparin to bind to the antithrombin, you need this sequence, which is very important, okay? And same here as well. If you notice here, that's the important sequence, which binds to the antithrombin. So once the heparin is bind to the antithrombin, and already the heparin as well is binding to factor 2 here, the prothrombin, you're gonna see a special bond between the antithrombin and the factor 2. And this complex is the heparin antithrombin factor 2 complex. Same thing for factor 10 again. So this is the heparin, this is the antithrombin, and this is factor 10. And you see again the green bound. It binds the heparin to antithrombin, and heparin as well is binding to factor 10, and antithrombin is binding as well to factor 10. And this is the complex. So that's the complex. So in terms for the heparin to bind to factor 2 or prothrombin, you need at least minimum of 18 saccharides unit to bind and form the heparin antithrombin factor 2 complex. If the units is less than 18, so if it's like 13 as it's here, this you're gonna form the 10. So you're gonna end up with heparin, antithrombin, and factor 10 complex. Okay, and remember this special bound that it needs. This need heparin to get bind to the antithrombin. This is just available only in 1/3 of heparin molecules. So not all of the heparin molecules. So 1/3 only. And this is why sometimes we see variation from patient to patient as well in terms of how they respond to heparin dose. So just remember this, guys, okay? Remember the special bond, and remember that this is special for a heparin to bind to antithrombin. And once you bind to antithrombin, everything comes indirectly as well. So antithrombin binds to factor 10 or factor 2, and you initiate the effect of heparin. Does anyone knows what's the dosage that we use of heparin as anticoagulation for CPP and every day in OR?
300 to 400 units per kg.
Okay, that's nice. Yeah, so it's 300 to 400 units per kg. And usually the route of administration, we give it, as anesthesiologist, we give it in the central vein. So usually in the central line. And we should document as well that we can aspirate blood before giving it in the central line, just to make sure that it's already in the system. Then after we give the heparin as a bolus, it binds to different cells. So it binds, like if you can see in the figure here, it binds to the endothelial cell. It binds as well to macrophages. It binds to the plasma protein. And obviously it binds to the antithrombin, as we said before, and the antithrombin will form the complex with factor 2 and factor 10. And the remaining heparin, it just circulates in the blood unbound. So this is what happens to the heparin once we give it as a bolus. How to monitor heparin anticoagulation effect in OR? Anyone? This is an easy question, I guess.
ACT.
ACT, okay. So we do something called activated clotting time, or ACT. How it works, it's just as a simple test that it works by mixing fresh whole blood with contact activator, usually kaolin or sealet, which mimics the surface of the cardiopulmonary bypass circuit. So when the blood just touched the circuit, so it mimics the same thing, okay? And this test initiates the intrinsic pathway of coagulation cascade and end up with the common pathway and leads to the fibrin clot. So the multiple steps occur as in here in the test tube, and the end point is just measuring the fibrin clot And the ACT is just measures the time from transferring the blood from liquid form to a gel form and making the clot. So the normal ACT is 105 up to 167 seconds. Anybody knows what's our target for ACT in intra-op, like during cardiac surgery?
480.
Okay, so yeah, usually it's different from one institution to another. But the main thing, the target ACT for CVB should be above 400. So 400 to 480, some people, they say 450. It's just different from hospital to hospital. But it should be like always like 400. Although you can institute, as we will see later, that you can institute the CVB with some lower ACT in some special circumstances. So we mentioned the ACT, so let's just discuss about the factors as well affecting the ACT. So all the factors that is affecting our ACT is hypothermia, hemodilutional, and obviously medication like heparin, warfarin, platelet inhibitor, and direct thrombin inhibitor, and protamine. So if you notice, all of these things, we see it every day in cardiac surgery: hypothermia, hemodilutional, and medication, obviously heparin, and sometimes platelet inhibitor as well. The other factors that affect ACTs, platelet counts, and exactly it's thrombophilia or increasing platelets, because as we mentioned before, heparin can even get bound to the platelets. So this is one factor can affect your ACT too. The other thing as well is the factor deficiencies, usually the contact factors like factor 12, factor 11, and kallikrein as well, or the intrinsic pathway factors like factor 8, antithrombin obviously, common pathways factors deficiency like 5 and 2, and fibrinogen. And there is some other disease states like connective tissue diseases with antibodies like anticardiolipin and antiphospholipid antibodies. So all these factors play a role in your ACT. So put this in your mind. We have two main problems with heparin. Do we know what's the two major problems we have with heparin? Any volunteers?
Resistance or induced thrombocytopenia.
Nice, yeah. So yeah, we mentioned it earlier before. So yeah, so we're gonna talk about heparin resistance now. Heparin resistance is the term used to describe the inability to achieve an adequate heparinization despite giving the conventional doses of heparin. So you fail to get an ECT more than 400 seconds with a heparin dose more than 600 units per kg, okay? So this is the definition for heparin resistance. The mechanism, as we mentioned before, if you know how the heparin works, you can guess the mechanism as well. So mainly it's antithrombin 3 mediated, although you have still non-antithrombin 3 mediated. So let's talk about the antithrombin 3 mediated causes of heparin resistance. So first of all, if you have a reduced synthesis for antithrombin 3, and this can be hereditary or in case of liver dysfunction. The other reason for antithrombin 3 mediated heparin resistance cause, it's accelerated clearance. So you have either reduced synthesis or accelerated clearance through the kidneys, and especially if you have nephrotic syndrome. Okay, so if it's either liver dysfunction or renal dysfunction. Or the third thing can be is accelerated consumption. And usually we will see accelerated consumption of antithrombin 3 if you are using preoperative unfractionated heparin or low molecular weight heparin. So this makes sense because you are just consuming your antithrombin 3. The other reason for accelerated consumption, if you have homeostatic system disease, say like DIC, endocarditis or DVT, pulmonary embolism or sepsis. This is as well consume your antithrombin 3. The third thing, if your patient is a mechanical support device. like CBB or ventricular assisted device, intra-aortic balloon pump, or ECMO. So all these reasons consumes or accelerated consumption of antithrombin 3. So most important thing, reduced synthesis due to liver dysfunction or can be hereditary, or increased clearance with renal dysfunction or nephrotic syndrome, or accelerated consumption due to the reason that we discussed. So this is all that's the reasons that antithrombin 3 mediated for heparin resistance. Still, you can end up with non-antithrombin 3 mediated reasons. One of them is increasing heparin binding. We mentioned that the heparin, once given IV, it binds to the platelets and protein and macrophages and different kinds of cells. So if it's increased binding, you're going to end up with the same thing with heparin resistance. And this is obviously, it's not antithrombin 3 mediated. One thing special, that medications as well, like nitroglycerin. Nitroglycerin, there is a special unique interaction between nitroglycerin and the heparin. It's not defined in the literature, but the interaction is there. So usually patients on nitroglycerin as well, they tend to develop some way of heparin resistance. So this can be a reason as well for heparin resistance, but it's not due to antithrombin 3 mediated, okay? So what's our options to treat the heparin resistance? We have different options. Number one, we can give additional heparin. We mentioned that you can, the resistance is once you give 600 units of heparin per kg, and you can't achieve your target ACT, which is 400. So you can give more heparin. This is an option. But just remember, if you give more heparin, your patient post-op going to be in the ICU, and you're going to end up with some chest tube drainage, which is going to be more. So this option does not come without a cost. It's easy. You can give more heparin, even more heparin, but you need to keep this in mind because it may interfere with the chest tube drainage post-op. The other option is administering fresh frozen plasma. And usually the fresh frozen plasma, 1 ml of fresh frozen plasma contains 1 unit of antithrombin 3. So if you give like 2 to 3 units of FFP, it's usually enough. Like you are giving around, let's assume that the FFP is 250 mils. So you will be giving around like 500 to 750 units of antithrombin 3. Obviously, this is what's more visible we can do, but it comes with the risk as well of administering blood products, like infection or some unwanted reactions as well. Third option of treating heparin resistance is giving antithrombin concentrate, and it comes in 2 forms, purified or recombinant forms. And the standard dose for this is like 500 to 1,000 units of antithrombin 3 concentrate. This is a good option, but it's a bit expensive compared to the fresh frozen plasma. So you need just to check the cost effectiveness, okay? What have here in King Fahd Medical City? I believe we have antithrombin 3, but usually we reserve the option for FFP because this is more practical. The fourth option, and this is the last resort option, is accepting an ECT below the target, which is below our 400. But this option, you don't need to do it unless your patient is unstable and at least your ECT is more than 300, because all these studies suggest that you can institute a safe cardiopulmonary bypass once the ECT is above 300. So you need to keep in your mind, like, never do this unless your patient is severely unstable and still your ECT is at least above 300. And this is the last resort. This is the last resort. If you are doing a straightforward case, you should not put even this number 4 in your mind. But if you are doing an emergency case and it's in the middle of the night and patient is having resistance for any reason, you can consider this option. You can. I'm just saying you can consider, okay? Let's talk about the other problem with heparin, heparin-induced thrombocytopenia. HIT is rare, but is usually potentially life-threatening reaction. And it develops, like patients develop antibodies to heparin platelet factor 4 complex, which is induced platelet activation, thrombocytopenia, and it can increase the risk for venous and arterial thrombosis. And we have two types of heparin-induced thrombocytopenia. We have type 1 and type 2. Type 1 is usually mild, type 2 is more severe. So type 1 is usually, as I said, it's mild. It happens in the first to the fourth day post-op. It's non-immune mediated, and it gives mild or at least to mild thrombocytopenia despite the continuous use of heparin, resolves spontaneously, and occurs primarily with high dose of intravenous heparin, and usually doesn't have any clinical sequelae. Type 2, which is the more severe form of heparin-induced thrombocytopenia, it's an immune-mediated, and classically it happens on the 5th day post-op up to the 14th day post-op. And the thrombocytopenia is very severe compared to type 1, and occurs with a dose of heparin by any route, any dose and any route. If you notice type 1, you need a high dose of IV heparin. But type 2, it can happen with any dose, any route. And usually type 2 does not cause bleeding problems, but it causes very serious thromboembolic complications. And obviously, you need to discontinue heparin. This is the test that you can do if you want to make sure. This is the 4T test that it can give you a clue if your patient is developing HET or not. So if you notice here, you have thrombocytopenia, time, thrombosis, and other causes, and you have a score here from 0, 1, and 2. Okay, so if the thrombocytopenia, the drop is more than 50%, you give a score of 2. If it's 30% from the baseline, obviously. If it's less than 50%, like from 30% to 50%, you give it 1. And if it's less than 30%, you give it 0. For timing is if it's within 5 to 10 days, as we said, you give it score 2. More than 10 days, 1. Too early, 0. For thrombosis, if there is new thrombosis or skin necrosis, 2. Recurrent thrombosis and erythematosis of skin lesion is 1, or if none is 0. Other causes, like if you have other causes for this, if there is no other causes can lead to this picture, you give it like 2. If you have some possible cause, you give it 1. If there is definitive other cause, you give it 0. So how this test works? If your score 0 to 3, you have low risk for HET. If it's 4 to 5 is intermediate, and obviously if it's 6 to 8 is high. The maximum score you will have, like if you give 2 by 4 items, you're gonna end up with 8. So this is how you can diagnose, or at least you can make your mind. Obviously, there's investigation we can do, which is the heparin-induced serotonin assay, which is the gold standard for HET. The other test is the enzyme-linked immunosorbent assay, ELISA, which is specific for heparin platelet factor 4 complex. Okay, so the gold standard is this. So when you have the probability with the score high, you can do the assay, which is the gold standard, just to make sure about your diagnosis. Once you diagnose that you have heparin-induced thrombocytopenia, obviously you need to stop the unfractionated heparin, and in case if the patient is going for cardiac surgery, you're going to use heparin alternative. So what's the most 3 important drugs that we are focusing on as a substitute for heparin, as anticoagulation for cardiac surgery? These 3, which is the direct thrombin inhibitor. It inhibits the thrombin directly. So liberudin, argatroban, and bivalirudin. Okay, so they are direct thrombin inhibitor, and we can just talk about them here. So liberudin is just like excreted or the clearances from the renal side. Argatroban is hepatic. Bivalirudin is renal and enzymatic as well. Monitoring, you can monitor them with ECT, and this is what's important for us, ECT, because we are using ECT in the OR. So you can monitor the ergotroban and bivalirudin, okay? Do they affect the INR? Obviously, yes. Do they cross-react with the heparin-induced thrombocytopenia antibodies? No. And they are all approved to be used in HET. So we need to focus more on bivalirudin and ergotroban. So what's the dose for bivalirudin? It depends, like it can be used as well for BCI. So this is the dose for the BCI, 0.75 milligram per kg bolus, followed by 1.7 milligram per kg per hour. This is for BCI, okay? For the cardiac surgery, obviously this dose become more higher and targeted with the ECT, okay? Ergotroban, you need to use, this is the dose, 25 mics per kg per minute infusion. And you can give 350 mics per kg bolus until the ECT, at least, as we said before, safely more than 300 seconds. And for the bivalirudin, you need to give like 0.4 milligram bolus and 0.15 milligram per kg as an infusion, and you target BTT. So the most two that we use is bivalirudin and ergotroban. Let's talk about protamine now. So protamine is the drug that we use to neutralize heparin. So it's highly alkaline protein derived from salmon sperm, and combining protamine, which is positively charged, with heparin negatively charged as well, produces stable complex devoid of anticoagulation activity. So heparin and protamine combine in proportion to weight. So 1 milligram of protamine neutralizes 1 milligram of heparin, and 1 milligram of heparin equals 100 units of heparin. So 1 milligram of protamine neutralizes 100 units of heparin. So how do you give the protamine? How you decide about the dose? Either you can use the empiric ratio, which is giving 0.6 up to 1.3 milligram of protamine for every 100 units of total heparin administered during the cardiac surgery, including the one that it was administered on pump as well. The other way of giving protamine is estimated from heparin dose response curve. So if we can look here, you see in the x-axis you have ACT, y-axis you have heparin and protamine. So when you do a baseline ACT, let's assume it's like maybe 120 or something. So you draw a point, then you give, let's assume you are giving almost 300 units of heparin per kilogram, and you will end up with a different ECT. So you can put here, oh, I give 300 units per kg of heparin, and my ECT is, let's assume 500. So you put another point, and you draw a line from the baseline to here. And with this line, you can as well, you can assume what's your protamine dose. If you can see here, you start from 0 up to 4. Usually we don't do this technique because it's time consuming. So as anesthesiologist, we use the empiric ratio. And anesthesiologists are different. Some anesthesiologists, they use 0.75. Some people, they reverse 1-to-1. Some people, even they go higher. So it depends on the anesthesiologist as well. The most important thing that we need to discuss is how we can administer protamine, because this is the most important and critical step. So the rate of administration is always more important than the route of administration. Like the studies showed, there is no difference in is giving heparins in the central venous catheter or the peripheral. But just like the rate of administration is the way more important in preventing adverse hemodynamic effects. Always remember, administer protamine slowly. And some people, they advise for using the continuous infusion techniques through syringe pumps rather than the hand-operated administration. Because in the hand operating, you're gonna just give boluses after boluses after boluses. But with continuous infusion, you're just having controlled infusion. The minimum duration of administering Protamin when we are reversing heparin is 3 minutes. This is the minimum, and the targeted is 10 minutes. That's the recommended. As I mentioned before, the route of administration is not, there's no evidence suggesting giving it peripheral is way better than central. The more important thing is just diluting the Protamin and just giving it very slow. Some clinicians and some anesthesiologists, they advocate for Protamin test dose. So they give just 1 milligram and they just wait to check if there is any reaction or anything. You can still get the same goal by giving a continuous slow initiation of continuous infusion through a syringe pump, for example. It can give you it can approach the same objective. Adverse effect of giving Protamin. The first side effect is the hypotension from rapid administration. So again, when you give it slow, is way better. When you give it quickly, you're gonna end up with problems. So when you administer it very quick, like when you give like almost 3 milligram per kg over 3 minutes or less, but you're gonna end up with both systematic and pulmonary arterial pressure, and this can lead to a decreased venous return. This can lead to a release of vasoactive compounds from the mast cell and leads to the hypotension. The other problem as well is leading to pulmonary vasoconstriction, and this can lead to acute RV failure. This is a very dangerous side effect of Protamin, and this is believed to be because of production of thromboxane by pulmonary macrophage. And this is due to large heparin-Protamin complex. The other problems of Protamin is impairment of platelet aggregation. It can lead to a transient thrombocytopenia and inhibition of plasma coagulation as well. Anaphylactoid reactions can happen, and always remember to screen your patient preoperatively. So this is the risk factors for true allergy for Protamin. If there is previous reaction to Protamin, in case of the patient booked for redo, if the patient is allergic to fish, if there is an exposure to MBH insulin, and if this patient is allergic to any other drug. Prior exposure is not considered as a risk factor. So patient like had an exposure before to Protamin, it's not considered as a risk factor. So always remember to screen your patient, the one that they are booked for cardiac surgery, about if they have some risk that gives them Protamin reaction. How we can deal once we...
Doctor, but the allergy to fish is not considered a contraindication for giving Protamin those days.
No, it's not a contraindication. It's these can make the patient as a risk for developing some side effects from Protamin. It's not a contraindication. This is it. Yeah, it can.
Even for the risk of allergy, because what I know is that the older generation of Protamin was extracted from fish. That's why.
Yeah, I understand what you're saying. Yeah, so this is still conflicting. So some people they tend to stick to the old, and some people they say no, it's not anymore as allergy. So it depends, like, you know, it depends which kind of following. But I think it's still like I believe in it, like, you know. But yeah, like the recent papers they said it's not anymore. So it's just like you need to keep it in mind. Like, okay, it's not obviously a contraindication anyway, but like when you start giving Protamin and something happen, you may suspect that he may have some potential risk for true allergy. Okay.
But for practically, because I had a patient like this, I faced a patient like this. If a patient report to you that he has a fish allergy,
it's not a contraindication.
Yeah, you will still give him in the OR.
Yeah. It's not a contraindication, but you're gonna be very cautious. You get what I mean? So you're gonna be it's not a contraindication. It's not. Yeah.
Thank you.
So how we can manage the adverse Protamin reaction? So we said if the systemic hypotension happens within 10 minutes of Protamin administration, This is usually suggest like after 10 minutes of the Protamine administration, suggests that Protamine is the cause, but you need to rule out all other causes as well when you are coming off pump, like hypovolemia or left ventricular systolic dysfunction as well. Once you make sure that you ruled out everything, and this is it's related to Protamine, the management that you're gonna do, it depends on the hemodynamic profile you have. So if you have normal or low pulmonary artery pressure, this is suggest either you give Protamine very rapidly or it's anaphylactoid reaction. Some of you are gonna tell me, yeah, okay, but we are not doing a pulmonary artery catheter anymore. So yeah, as an anesthesiologist, if we are using a transesophageal echo, we can estimate the pulmonary artery pressure, okay? This is for us as an anesthesiologist as well. For us all, as a surgeon and anesthesiologist, we can look at the RV. If the RV is distended or the RV is not distended. So if the RV is distended, we may say, it's high pulmonary artery pressure. If the RV is not distended, we're gonna say, it's normal or low pulmonary artery pressure. So if you have a picture of a patient with normal or low pulmonary artery pressure, the cause is either rapid administration or anaphylactoid reaction. Do you know how we can treat these problems if it arises? Any volunteers?
Stop the Protamine first.
Okay, stop the offending agent, yeah.
Yes, then support the circulation until we can resume giving the Protamine again, or we can just wait for the heparin to reverse by itself.
Okay, so yeah. So as we said, you need to stop Protamine, obviously. Then you need to give rapid fluid administration in case if the cause is rapid administration of heparin, of Protamine. And if it's anaphylactoid, you need to be very aggressive with volume resuscitation. But in the other, put in your mind as well that this is cardiac patient, so you may balance the risk and benefit of giving volume overload, okay? In case if you have very severe LV systolic dysfunction, okay? The second thing is initiating epinephrine, which is gonna treat your anaphylactoid reaction, plus minus as well norepinephrine as a vasopressor, and you can give as well inhaled bronchodilators in case if you end up with bronchoconstriction, which is the true picture of anaphylaxis. If you have a problem, let's say that the problem is the RV is distended, and I'm gonna tell you as an anesthesiologist, I have a very high pulmonary artery pressure. So this is suggest that the problem is pulmonary vasoconstriction reaction. So how are we gonna treat acute RV failure with very high pulmonary vascular resistance and very high pulmonary artery pressure? Any volunteers?
Nitric oxide.
Okay. What else?
So
I didn't hear you.
Hello.
Okay, so
can I answer this?
it's okay. We're gonna carry on. No worries. So you can start inotropes, which supports the RV, and the inotropes that you're gonna start, as well something with pulmonary dilating properties like milrinone. So this is your first line because the problem is high pulmonary artery pressure and high PVR, and it leads to acute RV failure. So you need to support the RV. As we mentioned as well, you can consider inhaled nitric oxide. If these two lines of management is not helping you, you can reinstitute the CBB again in case of very extreme hemodynamic deterioration. And for this, you need to give obviously a full heparin dose, around 300 units per kilo minimum. And sometimes when you give the full heparin dose, like 300 units per kg, this heparin alone, it corrects, like occasionally, it corrects the pulmonary hypertension that resulted from Protamine. And this is because of breaking up the large heparin-Protamine complex, which stimulates the thromboxine production, which is this cause of pulmonary vasoconstriction in the first place. So just remember, is the RV is distended or not? So is it distended or not distended? And you can manage accordingly. Once you make sure that the reason is not any other thing, not related to Protamine. let's discuss now the special cardiac lesion as well. So we're going to start with the coronary artery disease. The most important thing in the coronary artery disease is the balance between the myocardial oxygen demand and supply. Okay, so how are you going to increase your oxygen demand? By three things. If you are increasing the contractility, or if you are increasing the heart rate, the myocardial oxygen demand going to increase, or if you are increasing the wall stress as well. So if you are increasing these three, you're going to increase the myocardial oxygen demand, obviously. So the wall stress is Laplace law. So the pressure multiplied by the radius divided by 2 multiplied by thickness. So if you have a pressure overload, you're going to have more wall stress. If you have volume overload and the dimension of the left ventricle is high, you're going to have more wall stress. But if the ventricle is very thick, you will have less wall stress. So this is very important, you know, you need just to make sure to remember this. Okay, just remember this. This is the demand. So if you have tachycardia, you're increasing demand. If you're increasing contractility, you're increasing demand. If you're increasing the wall stress, like pressure or volume overload, you're increasing demand. Or if you're increasing the thickness, you are decreasing the wall stress and decreasing the demand. So the supply, we're gonna discuss about the coronary blood flow. So the coronary blood flow equation is the diastolic pressure, the aortic diastolic or systemic diastolic pressure minus the left ventricular end diastolic pressure divided by coronary vascular resistance. So that's why hypotension is very bad for coronary artery disease patient. And distension is very bad as well, because it increases your wall stress and decreases your coronary blood flow too as well. One more thing as well that you need to consider with the coronary blood flow is the diastolic time. So the more diastolic time you give, the more coronary blood flow you will give. And your diastolic time, it's inversely proportional to the heart rate. So when the heart rate is high or the patient is tachycardic, you have less diastolic time and you have less time to perfuse the myocardia. So tachycardia is very, very, very bad because it increases the demand and decreases your diastolic time and coronary perfusion as well. Okay, so remember that tachycardia is very bad, and hypotension obviously is very bad as well. The other factors that affects the myocardial oxygen supply is the oxygen content. So you want to make sure that you augment the hemoglobin and the saturation as well. Okay, and obviously the hemoglobin oxygen dissociation curve at the physiological condition. So what's our coronary artery disease hemodynamic goals as an anesthesiologist and for you as well as a surgeon? And us in anesthesia, we use this form. So we are focused on preload, afterload, contractility, rate, and rhythm. This is the most important 5 goals. Preload, afterload, contractility, rate, and rhythm. To make it simple for you, for all the lesions we're going to discuss now, if you can keep the rhythm always as a sinus rhythm, this is the best thing. So you don't need to remember that sinus is always is good, okay? So the only thing we need to focus on is preload, afterload, contractility, and rate, okay? So for coronary artery disease, as we mentioned, for preload, you don't need to over-distend the left ventricle or the heart itself all, because when you distend, you are increasing the wall stress. So when you keep the heart small, remember to keep the heart small. So you are decreasing the tension, you are decreasing the diameter as well, and you are decreasing the left ventricular end diastolic pressure, okay? Which is in turn increases your coronary perfusion pressure because you are dropping the LVEDB, okay? For the afterload, you need to maintain the afterload. If you have a scenario by choosing hypertension or hypotension, as we discussed before, hypotension is very bad. So hypertension is slightly better compared to hypotension, but if you can keep the patient as it is, that's the best thing. So your enemy here is the hypotension, okay? Hypotension and the distension of the heart, okay? This is the most important thing for the coronary artery disease. Contractility, it depends. If the ejection fraction is fine, let's assume that he's 50 or 55 with intact ejection fraction, You can decrease a bit the contractility, because when you decrease the contractility, you're decreasing the demand. But obviously, you cannot depress the contractility if the ejection fraction is 20. You need, obviously, to support the contractility. So it depends. It's tricky. It depends. Are you dealing with good ejection fraction or severe systolic dysfunction? For rate, as we mentioned, your enemy is tachycardia. So as we mentioned before, because of the demand and the diastolic time. So try to keep them slow to normal rate. Tachycardia is very bad. And rhythm, as we mentioned, sinus. So what you need to remember here, keep the heart small, avoid hypotension, and keep the rate on the low normal, like from 60 to 80, not more than that, okay? Aortic stenosis, the pathophysiology, we know that the aortic stenosis is a mechanical obstruction to the forward flow. It leads to pressure overload, and this pressure overload makes the LV wall mass hypertrophied and concentric hypertrophy. It means the chamber cavity gets small and the walls get thick and grow to inside. So once you have a concentric hypertrophy, if the LV is compensating with the pressure overload, the wall tension will be normal and the afterload will be normal, contractility will be normal too, but you're gonna end up with a stiff left ventricle. So the compliance will go low. And this stiff left ventricle will not allow for early filling for this left ventricle, and it will be dependent on the late filling. The late filling is dependent to the atrial contraction or the atrial kick. So the atrial kick becomes very important when you have very thick LV, because the LV is very stiff, doesn't relax, it doesn't suck the blood, so it's dependent on the atrial kick. So the atrial kick, it can even reach 30 to 40% of the LV filling in very hypertrophied LV. So that's why it's very important to keep the sinus rhythm. You can't sacrifice giving away the sinus rhythm. And obviously, if the LV is compensating, you're gonna maintain your forward flow on the stroke volume. If the LV started to decompensate, you're gonna have fibrosis for the LV, the wall tension gonna increase, the afterload gonna increase, the contractility gonna drop, the compliance again gonna become stiff, and same thing. So the LV cannot keep up, and the LV gonna dilate, and you're gonna lose your forward flow, and the stroke volume gonna drop, and the forward perfusion gonna drop, and the cardiac output gonna drop. What's our hemodynamic goals for the aortic stenosis? You need to maintain full preload. You can't sacrifice the preload. The afterload, always. These patients are in very high risk of developing ischemia as well, myocardial ischemia, because of the thick LV. So you need to maintain coronary perfusion gradient by maintaining, as we remember, if you can remember again, by maintaining the diastolic pressure, so avoiding hypotension, and if you can depress the LV. So hypotension is your enemy here. You can't sacrifice having hypotension in severe aortic stenosis patient as well. Contractility usually is not a problem if it's compensated, but if it's decompensated, you need inotropic support because you need to augment the cardiac output. In terms of rate, you need to avoid bradycardia, severe bradycardia, like very, very low heart rates, like 30 beats per minute. And obviously the tachycardia, as we discussed before, is very bad, especially in the aortic stenosis, because it can lead to ischemia, okay? Sinus rhythm is very important because, as we mentioned, of the late filling, because the atrial kick is giving 40% of the filling. So if your patient is not in sinus rhythm, you need to, or if they are in the fast rhythm, you need to use beta blocker for them as well. This is myocardial oxygen consumption. So you need to avoid tachycardia and hypotension for these reasons. So your enemy here in the aortic stenosis is hypotension and severe tachycardia. Hypertrophic cardiomyopathy is almost the same with aortic stenosis, although the pathophysiology is a bit different. But in the terms of hemodynamic goals, they share everything except one thing. We're gonna mention it now. So it's quickly, it's just this, you have a subaortic obstruction or the LVOT obstruction. And so this subaortic obstruction is going to create pressure overload again, going to make the LV hypertrophied. And this obstruction is dynamic. It means it changes. In the aortic stenosis, it's fixed at the valve level. Here is upstream to the valve level. It's in the LVOT. So it's just dynamic. It changes according to condition. And this is how we call it dynamic, okay? So this subaortic obstruction leads to LV hypertrophy. The LV hypertrophy, again, gonna give you a stiff ventricle, prolonged LV relaxation, gonna increase the filling pressure. And this increasing the filling pressure gonna give you ischemia because of the LV-EDB, as we mentioned before. The obstruction itself as well, it can drop the forward flow. So you're gonna drop the blood pressure, and it leads as well, once we say this hypotension, it's gonna lead to ischemia. And it increases as well the LV systolic pressure because the LV now needs to push even more against resistance. And this is, again, can lead to ischemia. So the problem is ischemia now. So we'll end up with diastolic plus ischemia and systolic dysfunction at the end. Our goals, as I mentioned, this is the same like the aortic stenosis. So you need to maintain full preload as well, treat as aortic stenosis. The afterload, always you need to increase the afterload. And you need to avoid hypotension by any means. You need to treat hypotension aggressively with alpha-adrenergic agonists like phenylephrine. So to maintain the perfusion pressure, the cryo perfusion pressure, okay? Rate, you can use low normal rate. And obviously you need to avoid tachycardia because tachycardia is bad. And for rhythm-wise, as we mentioned, sinus rhythm is always crucial as well, okay? So it's almost the same, but the only different thing is the contractility. Contractility, you need, obviously the problem here is hypertrophic cardiomyopathy, so you need to depress the contractility. The more you augment the contractility, the more you're gonna create more subaortic obstruction. Your LVO2 becomes smaller and smaller, and you're increasing again the obstruction. So here, you need to depress the contractility. That's the only difference between hypertrophic cardiomyopathy and the aortic stenosis. And we said as well before, like we said, when it comes to the myocardial oxygen consumption, you need to monitor for ischemia. It's very important because they tend to have subendocardial ischemia, which is very bad for them. Mitral stenosis, again, it's a pressure overload problem, mechanical obstruction for forward flow. So you will have an increased left atrial pressure, which leads to increase in the left atrial size, which leads to atrial fibrillation, which it can lead as well to developing thrombus in the left atrium or the left atrial appendage. The increasing left atrial pressure gonna go back in circulation downstream, so gonna increase the pulmonary venous pressure. The pulmonary venous pressure gonna increase your pulmonary artery pressures. The pulmonary artery pressure, when it increases, gonna make the vasculature changes with time and gonna lead to increasing the pulmonary vascular resistance. Increasing pulmonary vascular resistance gonna give some trouble to the RV. So the RV gonna push hard against resistance, and it's gonna have like pressure overload. And over time, we know the RV is not like the LV. So over time, the RV gonna dilate, fail, and leads to tricuspid regurg, and you're gonna end up with right-sided heart failure as well, okay? This is the cardiac side. So what happens to the lungs as well? So the lungs, you're gonna end up, as we mentioned, you're gonna increase the pulmonary venous pressure. You will end up with decreasing the lung compliance, congested lungs, and the work of breathing gonna increase more, and patient will not be able to breathe normally, okay? This is like in the atrial side. What happens to the ventricular side? You have a mechanical obstruction, so the LV filling is less, the LV stroke volume is less. When the LV stroke volume is less, you're gonna end up with sympathetic stimulation, and you're gonna end up with vasoconstriction, which is bad as well. In terms of goals, almost the same for the atrial, for the aortic stenosis. You need to maintain the preload and avoid, obviously, hypovolemia. You need to avoid hypotension by any means, again, Plus, you need to remember the factors that increases the pulmonary vascular resistance, because you don't want to overwork the RV. So you wanna make sure that the RV after load is less. So this is by avoiding, you're gonna avoid all the factors that increases the pulmonary vascular resistance, like hypoxia, hypercarbia, acidosis, which is the three main factors. Okay, you can use vasopressors, obviously, to maintain the flow, like to maintain the perfusion. For the contractility, usually the LV is intact and it's not receiving good filling, but the RV is the problem. So the RV is the problem here, and it's due to long-standing pulmonary hypertension. So you need to support the RV. The rate, always the stenotic regions, you need to maintain low to normal heart rate. And obviously you need to avoid tachycardia. So tachycardia and hypotension, your enemies here. And obviously, as we said, in terms of rhythm, you need to control the rhythm. Sinus is better, but usually they come in atrial fibrillation, so try to control their ventricular rate. The myocardial oxygen supply, the left ventricular myocardial oxygen supply, usually it's not a problem. The problem is in the left atrial side and the mitral valve as well. Aortic insufficiency, quickly, it's a volume overload. So the diastolic, there is a backflow, diastolic blood flow from the aorta to the LV. If it's acute, quickly, like happened quickly, like in case of aortic dissection, it's gonna increase the LV EDB. And once you increase the LV EDB, you're decreasing the stroke volume, ischemia, you're increasing the wall tension, you're decreasing the contractility, you're gonna end up with LV systolic and diastolic failure. If the aortic insufficiency is chronic, it's not an acute, you're gonna end up with the volume overload, left ventricular volume overload. This leads to eccentric LV hypertrophy. So the compliance and the filling pressure are normal, and the tension and the contractility is normal with compensation. Different than the acute aortic insufficiency. So the stroke volumes is increased because of the volume overload that's getting back to the LV. So you will have increase in the arterial systolic pressure, and you will have decrease in the diastolic pressure. And this is gonna increase the left ventricular systolic pressure. And this is with over time, it may lead to the left ventricular systolic dysfunction. In terms of goal, it's the opposite way for the stenotic lesion. So you can increase the preload, the afterload. You need to decrease the afterload here. So because you want to lessen the regurgent volume that it goes from the aorta to the LV. So if the systolic pressure and the diastolic pressure are low in the systemic circulation, you will have less volume going back to the LV. But how low you can go, you need to maintain your forward perfusion as well, okay? So you can drop the afterload, and usually as anesthesiologist, we can drop it with the increasing the anesthetic depth or using vasodilator. This is to decrease the regurgent fraction and the volume, as I said. Contractility usually is adequate if it's chronic and is compensated. Rate is opposite, you need to increase the rate. Because when you increase the rate, you reduce the ventricular volume because you are raising the diastolic and you're raising the diastolic pressure. So there is no gradient when you're, because this is a diastolic flow. So this is the diastolic backflow from the aorta to the LV. So if your aortic pressure is raised, gonna equalize almost with the LV, so you will not have more of volume going back. The rhythm is, as I said, is sinus, and there is no problem in the myocardial oxygen supply. Mitral regurg. So again, the pathophysiology, if it's acute mitral regurg, it's retrograde systolic ejection to the left atrium. So this volume overload increases the left atrial pressure and causes pulmonary edema. And this volume overload as well gonna overload your LV because the volume gonna go back to the left ventricle, so it's gonna increase the left ventricle diastolic pressure, which can lead to decreasing the systemic stroke volume. This is in case if it's acute MR. In case of any case, like if patient is ischemic and has ruptured papillary muscle, so this is in case of acute. In case of chronic MR, due to a problem in the valve, so you're gonna have normal to low left atrial pressure, because the left atrium now it has some time to compensate. So it grows more in size and it goes more in compliance. So this is gonna lead to atrial fibrillation and pulmonary congestion slowly over time. On the LV side, you're gonna end up with increasing the LV compliance and the size because of the volume overload. And within time, you're gonna end up with decreasing the LV contractility. What's the mitral regurg hemodynamic goals? Same preload you need to increase, same like the aortic regurg, same thing. You need to decrease the afterload, you need to decrease it with anesthetics or arterial vasodilator. Contractility may be depressed because of the LV as we mentioned here. So you need to titrate the myocardial depressant, and sometimes if the LV is bad, you need to support it. Rate, as we mentioned, you need to increase the heart rate a bit and avoid bradycardia, so you're avoiding the regurg volume to become more. Rhythm, as we mentioned, sinus is better, but these patients gonna be atrial fibrillation, so you need to have a rate control for them. And the myocardial oxygen supply or the myocardial oxygen consumption usually is compromised if the MR coexisted with ischemic heart rate, so you need to monitor for ischemia as well. Touching quick about the aortic dissection, your hemodynamic goals for aortic dissection, the most important thing, you need to decrease the afterload, so you need to keep the systolic blood pressure less than 100 to 120, not more than that. Avoid hypertension by any means. And you need to avoid as well increasing the contractility as well. And the rate should be low normal rate as well. Okay. Touching quickly on the, I know you maybe are tired now by this, but like this is touching out. We're gonna just touch base about our medications that we use, the induction medications. So usually what we are using as IV induction medications, anesthesia, usually we are using propofol, etomidate. Some circumstances still you can use ketamine. We use still as well midazolam. Thibontal, nobody's using it. Like still some people they use it, but in cardiac we don't prefer it anyway as a cardiac anesthesiologist. So for propofol, you need to remember the most important thing. Like it's what's the effect of the propofol? It will drop the blood pressure, which is we mentioned that it can be bad for most of our patients, if you remember. Etomidate is a cardiostable drug, and it does not have any problems with heart rate or blood pressure, but it has a problem with interfering of adrenal gland. So you may see the patient is ending up of having adrenal insufficiency in the ICU. Although it can be just transient for 1 or 2 days, and once you supplement with corticosteroids, it goes away. But like that's why some cardiac anesthesiologists, they don't prefer this. If I can achieve the same hemodynamic goals that I mentioned before. Ketamine, we don't use it in cardiac anesthesia unless if we are suspecting it's a cardiac tamponade. So because in cardiac tamponade, I didn't mention in the hemodynamic goals, you need to maintain the tachycardia and you need to maintain the vasoconstriction. So ketamine give you this, because ketamine gonna give you tachycardia and gonna give you as well increase in the blood pressure. So you're gonna find some anesthesiologists, they are using it in cases of re-exploration if you are suspecting there is cardiac tamponade. I'm not gonna bother you with the doses and the onset and everything, but just I put it here just for us. Regarding communication, this is the last thing I need to mention. Communication is very important between the anesthesiologist and the cardiac surgeon. And for me as a cardiac anesthesiologist, this is the most important thing, like the communication with the cardiac surgeon compared to the other colleagues from the other surgical specialty. Because we are dealing with high-risk patients, there is a lot of things going on. Sometimes you are pushing the heart and I'm not seeing, like, you know, so this is very, very, very important. I have a story, like this is a real story, by the way. There is one patient undergoing CABG. The cardiac surgeon was about to cannulate. So heparin was given. So the anesthesia, there was anesthesia resident and the anesthesia staff, the consultant. So the anesthesia staff, I think he was busy doing something or whatever. So anesthesia resident, he saw that the blood pressure is going, obviously is unexperienced anesthesia resident, like I think he was even junior. So anyway, so he was supporting the blood pressure. So there was some hemodynamic changes and the blood pressure is, you know, when we cannulate, you know, blood pressure tends to go down and all of this. So he gave a good dose of phenylephrine. So he gave a phenylephrine dose without communicating to the cardiac surgeon. He flushed the phenylephrine. The cardiac surgeon like cannulated. While he's cannulating, the pressure was like around 170 systolic or something like that. It was a problem. They went on pump. They found that there is an aortic dissection, needs to be repaired, and it was a very big problem, honestly. So communication is very important, especially between cardiac anesthesiologist and the cardiac surgeon, because it can lead to disaster. Thank you very much.
Thank you very much, Dr. Fahad.
Any questions or anything?
Thank you, Dr. Fahad. I just have a quick question. I know we don't see it a lot, but is there any consideration from anesthesia side in regards to doing off-pump CABGs? You know, we are manipulating the heart and the heart's not supported. So
yeah, it's off-pump. Off-pump CABG for us as a cardiac anesthesiologist is even more tough than on-pump CABG because there is a special consideration. Obviously, we know that there is a lot of manipulation in the off-pump CABG and the patient is not on pump. So from our own point of view, we need to maintain hemodynamics. As I mentioned before, that you need to maintain preload, you need to avoid hypotension, obviously you need to avoid tachycardia, you need to have a good preload for the heart, but you don't want to over-distend the heart because we are not on pump, we are not protecting the heart, we are not giving cardioplegia, we are not cross-clamping. So, and it's technically challenging for you too as a cardiac surgeon, especially if your target is it's not easy to reach and you need to manipulate. So it's challenging on both of us. So the special consideration from our own end is maintaining the preload, good preload, switching on vasopressors like starting norepinephrine just to maintain the perfusion as we mentioned, being very aggressive with tachycardia. We are aggressive with tachycardia to begin with, but if the patient is off pump, we need to be very aggressive as well so we can give you a chance, guys, you can work. You don't want to work on a heart beating 100 beats per minute. You want it a bit slower as well. So yeah, and it's just like it needs as well. We are using usually transesophageal echo, so it needs the volume management. It needs to be guided by the transesophageal echo because when you manipulate, like we're gonna see our CVP is going up. If we are putting a pulmonary artery catheter, you're gonna see it maybe going up. Yeah, so it depends. So everything should be under vision, and we use always TEE if there is no contraindication. And obviously the anticoagulation is, we accept lower target ACT compared to the full on-pump ACT. Any other questions?
يعطيك العافية دكتور. Actually الإكسبلانيشن حقك جاوب جميع أسئلتي. Thank you so much.
No problem. يعطيكم العافية. Thank you very much.
Thank you, Dr. Fahad. يعطيك العافية.
الله يعافيك.
Thank you, Dr. Fahad, for joining us and sparing this time with us. I hope we'll see you in another time. Believe we can have a quick break for 5 minutes, and then we'll start the third lecture.
Thank you, guys. Thank you.
دكتور أمجد.
ايوه
تفضل.
اوكي يعطيك العافيه. شكرا دكتور. طيب بسم الله الرحمن الرحيم. Good afternoon everyone. I'm Dr. Amjad Bernawi, cardiac surgery resident in South Baptine Cardiac Center in Eastern Province. Today, inshallah, I'm gonna talk about blood products and transfusion in cardiac surgery. So my outline like the following. I'm gonna talk basically about three main topics: blood products, blood transfusion, and guidelines at the same time, and some about complication and transfusion reactions. And each is gonna be subtopics. So at the beginning, for the blood products, first component with us here is the whole blood. Whole blood is collected in a bag containing the citrate phosphate dextrose adenine, which is abbreviated as CBDA solution. This citrate chelates the calcium present in blood and prevents coagulation. So it's provided in most of the hospital, like 1 unit that equal 450 ml. No functional platelet, no liable coagulation factors. It's stored in 2 to 6 Celsius. Shelf life is 35 days, and increase hemoglobin by 1 gram per deciliter for each unit. If you allow me, in these products, I'm gonna go through quickly a bit because it's only facts information.
Amjad?
Yes.
I think you have an issue with your mic. ما هو واضح الصوت، فإذا في مجال تعدله.
Is it unclear or low?
في صوت خربشة، ثبت المايك بس.
Okay. What about now? Is it okay now?
No, it's the same. يمكن المايك نفسه أجل.
Actually, I'm not using any. I'm using the computer mic. So previously, I think that the same thing happened. I'm not using any headphone or something. There is a sound right now.
صحيح.
What about now? Still?
أخف.
لسه موجود بس أخف شوية يعني إذا.
Okay, can I carry on or?
Yeah, you can if you cannot do anything.
This is the best I can do.
You can continue.
Okay. So for the whole blood, it's mandatory screening test. The hepatitis B surface antigen, the anti-hepatitis C virus, the anti-HIV, the VDRL for the syphilis, the malaria parasite also. Indication for transfusion, exchange transfusion in severe anemia, severe hyperbilirubinemia, and severe hemorrhage. The bagged RBCs, it's a platelet and plasma are removed. So 1 unit is equal 350 ml approximately. The hematocrit is 65 to 75%. The shelf half-life is 35 days or 5 weeks. It's stored in 2 to 4 Celsius degree. Increased hemoglobin, the 1 unit increased the hemoglobin by 1 gram per deciliter in 70 kilogram adults, and the hematocrit by 3%. Cross-match blood can normally be provided within 20 minutes in bagged RBCs, and it contains blood from single donor, need to be. So there is one factor that I find it interested to be mentioned, the hemoglobin oxygen-based carrier, or HbOC. In one study shows that such a component, the hemoglobin oxygen-based carrier, polymerized bovine hemoglobin solution, which includes these 3 components, the hemopure or biopure and corporation, found that it's preserved oxygen transport and eliminated the need for transfusions in 34%. of patients after cardiac surgery, although the substantial doses of the short-acting product were required. So this polymerized hemoglobin preparations appear to be best blood substitute undergoing evaluation. We'll continue with the popular one, the washed RBCs. The RBCs that washed with the 1 to 2 liter normal saline, RBCs is 20% reduced, plasma is by 90% reduced, and WBCs by 90% reduced. The indication for washed RBCs could be to prevent febrile non-hemolytic reaction that we're gonna talk about later. Washing eliminate antibodies in patients with recurrent febrile reactions, post-transfusion, urticarial reactions, anaphylactoid reactions. So mainly any kind of reactions with the blood products. So next is platelets. The platelets are separated from the plasma by centrifusion. So 1 unit of platelet increase the platelet count by 10 multiplied by 10 or 10 power to 10 per liter in a 70 kilogram adult. Platelet are provided as units. 1 unit is 50 ml. That's why when we are ordering platelets, we order like 12 units. Platelets do not need to be cross-matched, but they should be ABO compatibility and rhesus matched in female of childbearing age. 1 unit contains platelet from single donor, and the platelet viability is optimal at 22 Celsius degree, but is stored and limited to 4 to 5 days only. Sorry. So transfused platelets will be less effective when given within 6 hours of loading dose or 4 hours of maintenance dose, especially if there is clopidogrel or prasugrel, because the active component is still present in the bloodstream, so it wouldn't be effective. They found nearly 33,000 patients from Cleveland Clinic confirmed increased postoperative morbidity in patients receiving platelet. But after risk adjustment, there was no increased morbidity or mortality from transfused platelet. Prophylactic platelet transfusion is ineffective and rarely indicated when thrombocytopenia is due to increased platelet destruction, for example, in ITP. So having said that, the contraindication to platelet transfusion is TTP and HEPT. Fresh frozen plasma or FFP. Plasma is separated from the RBC's component of whole blood by centrifusion. Again, same concept as the platelet. 1 unit has volume of 150 to 250 ml approximately, and contains all plasma proteins, particularly factors 5 and factor 8. Factor 5 by 66% and factor 8 by 41% in normal individual, but no platelets. This is the difference. So the 1 ml of FFP per kg will raise most clotting factors by 1% in 70 kilogram adults. So 1 unit of FFP usually contains product from single donor, but sometimes pooled, in which case it may be from several donors. This is something that we don't find in the other products, as I mentioned, like RBCs and platelets. FFP does not need to be cross-matched, but should be ABO compatible, the same as platelet. Should be stored at temperature of less than minus 30 Celsius degree, and to be thawed in blood bank at 37 Celsius, usually over 20 minutes before giving, and discard if not used within 2 hours. So from 2 to 4 units for average adult, 4 units will increase the level of clotting factors by 10%, which is considered to be amount necessary to improve the coagulation factor. This is for the FFP. So the indication for FFP, what is the indication? For urgent reversal of warfarin therapy, for example, for correction of non-coagulation factor deficiencies for which specific correlates are unavailable, for correction of microvascular bleeding in the presence of increased prothrombin time or partial thromboplastin time, for correction of microvascular bleeding secondary to coagulation factor deficiency in patient transfused with more than blood volume and then PT or PTT cannot be obtained at the timely fashion. Treat heparin resistance due to antithrombin 3 deficiency, and also treatment for TTP. So next is Cryo Precipitate. From its name, it's which is abbreviated as cryo, and it's the precipitate or the precipitate remaining when the FFB is thawed slowly at 4 degrees Celsius. It is a concentrated source of factor 8, 13, 1 Willebrand factor, and fibrinogen. One bag is containing 150 to 250 milligram. 10 bags of cryoprecipitate raises the fibrinogen 0.6 to 0.7 milligram per liter in a 70 kilogram adult. One bag of cryoprecipitate equal 20 ml. 5 to 10 pooled bags are normally given for cryoprecipitate. So the APA compatibility is not essential because of limited antibody content of associated with the plasma vehicle. This is for, again, something remarkable or for cryoprecipitate. Viruses cannot be transmitted with the cryoprecipitate. It can be transmitted with the cryoprecipitate. It is stored at minus 20 Celsius degree and thawed immediately prior to use. Cryoprecipitate used in treatment for factor 8 deficiency, hemophilia A, von Willebrand disease, and fibrogen deficiencies. It may also benefit patients requiring surgery soon after thrombolytic therapy, which significantly reduce fibrinogen levels. So if you need to take someone urgently, you can give them in prior cryoprecipitate. Last two factors, which is, as mentioned in Lawrence, the novel factors for the blood products, the recombinant activated factor 7, endogenous activated, which is endogenous activated factor 7, plays a central role in coagulation. The recombinant factor 7 is approved by the FDA for management of bleeding in patients of hemophilia A, type B, and patient with congenital factor 7 deficiency as well. Current blood conservation guidelines state that recombinant factor 7 may be considered for management of intractable non-surgical bleeding, that is otherwise unresponsiveness to conventional hemostatic therapies. Yet the routine prophylactic use of recombinant factor 7 in cardiac surgery cannot be endorsed for reasons of cost due to limited data and its efficacy, and because of concerns for increased risk of serious adverse event with this blood product. Last one is the prothrombin complex concentrates, or PCC. PCC are plasma derived concentrate of vitamin K dependent coagulation factor, as we know, factor 2, 7, 9, and 10, and protein C and S. Several PCC products are currently available. PCC are useful for rapid reversal of oral anticoagulants like warfarin in a randomized trial cardiac surgical patients. PCC reverse oral anticoagulation safely, more quickly, and decrease bleeding compared to reversal with FFP. PCC are also beginning to studied for the treatment of post-cardiopulmonary bypass coagulopathy, and early results suggest that PCC usually may decrease the subsequent FFP and platelet transfusion requirements. Though these promising preliminary results have yet to be validated in larger randomized controlled clinical trials. So this is the part for the blood products. We're gonna shift gears to transfusion reaction and infections. So mainly we have several transfusion reactions and infections, acute hemolytic reaction, anaphylaxis and allergic reactions. We have the non-hemolytic febrile reaction, infections such as trali or other bacterial and viruses, delayed extravascular hemolytic reaction. And also there is non-immunological acute reactions like air embolism, hypocalcemia, hypothermia, and thrombophlebitis. So starting with the delayed adverse reaction, could be immunological or non-immunological. If it's immunological, delayed hemolytic reactions, DHR, or post-transfusion purpura. The non-immunological reactions could be iron overload or transfusion-transmitted diseases. For the non-infectious risk, some epidemiology and statistics, the non-infectious adverse reaction with their approximate incidence are acute hemolytic transfusion reaction, 1 in 25,000 to 50,000. Delayed hemolytic reaction or transfusion reaction, found in 1 in 2,500. Minor allergic reactions, 1 in 200 to 250, sorry. Anaphylactic reactions, 1 in 25,000 to 50,000. Febrile reactions, 1 in 200. And transfusion-related acute lung injury, TRALI, in 5,000. So, acute hemolytic transfusion reaction. When incompatible blood is given, antibodies and complement in the recipient plasma attack the antigen on the donor RBCs, which lead to hemolysis occur. And then the antigen antibody complex activated the Higman factor 12, which acts on the kinin system to produce the bradykinin. Bradykinin ultimately increase the capillary permeability, vasodilatation, and both cause hypotension. So this is the mechanism or the pathophysiology of so the signs and symptoms of acute hemolytic reaction: fever, chills, nausea and vomiting, diarrhea, rigors, hypotension, flushed appearance and dyspnea, chest pain and back pain. Patient is restless and has headache and hemoglobinuria. Management of acute hemolytic reaction. If reaction is suspected, the transfusion should be stopped immediately. This is the first action that you can do. And then the identity of the patient and the labeling of the blood pre-checked again. Management has two main objectives: maintenance of the systemic blood pressure and preservation of the renal function. So lab tests should be included to repeat cross-match and direct antiglobulin COMT test. Direct antiglobulin test is a definitive test for an acute hemolytic transfusion reaction. It examines the recipient RBCs for the presence of surface immunoglobulins and complement. Patient serum is also examined for the antibodies that react to the donor cell. So next is the delayed hemolytic transfusion reaction. This reaction occurs when the donor RBCs have an antigen that which the recipient has been previously exposed to transfusion or pregnancy, for example. However, over the time, the antibody fall to level too low to be detected by compatibility testing. When re-exposure occurs to the patient, undergo to an amnestic response and produce more antibody that eventually lyses the foreign RBCs. So the evidence of hemolysis is usually evident by the first or second week after exposure. That's why from its name it's delayed. Symptoms are low-grade fever, increased bilirubin, with or without jaundice, with reduction in hemoglobin level as well. the reaction itself limiting and the clinical manifestation resolve as the transfused cells are removed immediately. Sorry. Febrile non-hemolytic transfusion reactions. The etiology is the anti-leukocytic antibodies against donor leukocyte and cytokines from the donor leukocyte. So the clinical features will appear as fever, chills, flushing, and tachycardia again. Management, as always, first of all, to stop the transfusion, restart it slowly, treat with the paracetamol, and use saline washed or leuko-reduced cells. Transfusion-related infections could be viral, for example, hepatitis A, B, and C, which usually found in blood. Could be HTLV1 or HTLV2, the human T-cell lymphocytic viruses. Could be HIV or cytomegalovirus, which is more severe and aggressive. Could be Epstein-Barr virus as well. Protozoal infections could be malaria, toxoplasmosis. So the exposure estimates for hepatitis B is 1 in 350,000. Hepatitis C is 2,000, or 2 million. HIV in 2 million as well, and HTLV in 2,009 million. Bacterial contamination. Bacterial contamination occurs at a much higher frequency than any other infections and associated with substantial mortality. The rate of bacterial infection contamination in RBCs 1 in 30,000 and platelet 1 in 2,000. This is the incidence for the bacterial contamination. The patient who receives contaminated blood will rapidly experience some combination of fever, chills, tachycardia, emesis, and shock. The patient may also develop DIC and acute renal failure. If the index of suspicion is high, then the blood transfusion should be stopped immediately and blood culture is taken. But all this, I think, less in these days because the blood are screened very well. But although it's happening. So one of the main transfusion reactions that happen is transfusion-related acute lung injury, or TRALI. TRALI, it is a non-cardiogenic form of pulmonary edema associated with blood product administration. It is associated with administration of all blood products, but occurs most frequently with the RBCs, FFP, and platelets. So the incidence 1 in 5,000 units transfused. TRALI has mortality of 5 to 8%. The clinical appearance is similar to the adult respiratory distress syndrome. So the symptoms usually begin with 6 hours after the transfusion and often more rapidly. Patient develop dyspnea, cyanosis, chills, fever, hypotension, and even non-cardiogenic pulmonary edema, as we mentioned before. Chest X-ray reveal bilateral infiltrates. Severe pulmonary insufficiency can be developed as well. Treatment is largely supportive. The transfusion should be stopped if the reaction is recognized in time. The patient should receive oxygen and ventilatory support as necessary. So for the post-transfusion purpura, the antiplatelet antibodies usually found coming with such patient 5 to 10 days after infusion. Acute severe thrombocytopenia. The management should be like self-limited recovery in 21 days. IV immunoglobulin given. If not available, steroids or plasma exchange. Prevention by using leukodepleted component. And finally, the iron overload due to lifelong monthly transfusion, like beta thalassemia major, cardiac failure, cardiomyopathy, liver cirrhosis, hyperpigmentation of the skin. So this is for the blood products and the complication. I'm okay, Luay. I'm going too fast, too low.
Yeah, doing fine.
Okay. So coming to the last part of my presentation, which is the blood transfusion in cardiac surgery. As introduction for the blood transfusion in cardiac surgery, the patients in cardiac surgery undergoing to consume large numbers of RBCs transfusion, estimated about 20% of total blood supply. The main goal of blood transfusion is to increase the oxygen delivery, which is abbreviated as the D-oxygen, to tissue, and the oxygen utilization by cells, which is the V-oxygen. This is a really important concept. So it has to be observed that the cardiac surgery blood transfusion increases the delivery of oxygen while the oxygen utilization remains stable. So this is due to the enhancement of the erythrocyte rheology and therapy, improvement of blood physiology, as blood viscosity, perfusion, and hemodynamics functions. Although blood transfusion are necessary in cardiac surgery, several studies found that the blood transfusion had also deleterious effects and danger, such as the excess risk that we found, serious infectious complication, renal failure, neurological complication, prolonged ventilatory support in hospital mortality, increased resource of utilization and cost. So the infectious complications such as septicemia, bacteremia, or even superficial or deep sternal wound infection are higher for transfused patients instead of other factors and comorbidities. So the red cell transfusion to increase the oxygen carrying capacity of blood to avoid the end organ ischemia and dysfunction. This is the main goal of transfusion, especially in cardiac patients. So the tissue oxygen delivery depends on the cardiac output, hemoglobin level, and the oxygen extraction ratio in tissues. Because of that, the early postoperative period is associated with the delayed myocardial metabolic recovery, reduced cardiac output, significant anemia. Oxygen delivery is commonly reduced at least 25% postoperatively. There is some transfusion triggers. The transfusion is unlikely to improve oxygen transport when hemoglobin concentration is greater than 10. So no need to transfuse, and it's not recommended. Hemoglobin level below 6 grams per deciliter. Red blood cell transfusion is reasonable since that can be life-saving. Transfusion is reasonable in most postoperative patients whose hemoglobin less than 7 grams per deciliter, but not high-level evidence support this recommendation. In the absence of shock, this is from Bojar, I got. In the absence of shock, transfusion for hemoglobin less 7 grams per deciliter should be given 1 unit at a time. In the patient with borderline hemodynamics, dependent upon 2 or more pressors with hemoglobin between 7 or 8 grams per deciliter, red blood transfusion may be considered. Again, 1 unit at a time, and consultation between cardiothoracic surgery and the attendings may be, it need be to be warranted. So the transfusion, like other medication, this is an important statement. The transfusion is should be not ordered without knowledge or participation of the whole team, the ICU, the anesthesia. So it's not just adding some units to the patient because of low hemoglobin. Unless the hemoglobin is less than 7, that may occur without consultation between anyone. That might be significant. In patients whose hemoglobin exceeded the 7 gram per deciliter, consultation between the cardiothoracic surgeon and the attending is expected prior to elective transfusion. So the important about this slide, as mentioned by Dr. Fahad before, the communication for any kind of patients need to be transfused, any kind of blood, need to communicate very well between the ICU, anesthesia, cardiologist, even sometime, and to involve the attending doctor for sure. So also here I have a concept of triggering the oxygen capacity carrying of hemoglobin, hypotension, tachycardia, low cardiac output, state with a low mixed venous oxygen saturation that we know. Also metabolic acidosis, evidence of neurological impairment, respiratory insufficiency or renal dysfunction. All those, why it's happened? It's happened because of major enzyme, which is 2,3-DPG or diphosphoglycerate level in blood that is very low, especially when the longer duration of storage resulting in the leftward shift of the oxyhemoglobin dissociation curve with more avid binding of oxygen to hemoglobin and less release to the tissue. So fortunately, the 2,3-DPG levels return to 50% of normal within 24 hours after transfusion. And this is an important that I found to mention. So shifting the gears to the guidelines, I'm gonna mention in between the slide, as I put in the group as well, the referring guidelines of European Association Guidelines 2017. For the transfusion strategies, the recommendation, implantation of patient blood management protocol for the bleeding patient is recommended. This is class 1 level C evidence. The use of packed RBCs all ages is recommended because of the storage time in the packed RBCs does not affect the outcome. This is also class class 1 level A evidence. The use of leukocyte depleted packed RBCs is recommended to reduce the infectious complications. Sorry, this is class 1. This is class 1 evidence, level B evidence. Pooled solvents detergent of FFP may be preferred to standard FFP to reduce the risk of TRALI. This is class 2B, level B. Perioperative treatment algorithm for the bleeding patient based on viscoelastic point of care. Tests should be considered to reduce the number of transfusions. This is class 2A, level B. It's recommended that one transfuse packed RBCs on basis of clinical condition of patients rather than on fixed hemoglobin threshold. This is also class 1 level B. Hematocrit of 21 to 24% may be considered during cardiopulmonary bypass. This is class 2B, level B. In continuation, the adequate delivery oxygen, more than 273 milliliter oxygen per minute per meter square, level is maintained. This is the same. Platelet concentration should be transfused in bleeding patient with the platelet count below 50 or patient on antiplatelet therapy with the bleeding complications. This is class 2A level C. So the risk factor for transfusion, independent factor predicting the need of transfusion. The most likely is the lower preoperative hemoglobin, lower weight, older age, and female gender. Additional risk factor for preoperative transfusion include preoperative use of antiplatelet or antithrombotic drug, reoperation, acquired or congenital clotting coagulation abnormalities, complex procedures, and emergency operations. So preoperative blood transfusion, something to be considered. Should the patient in acute coronary syndrome and hematocrit of lower than 28%, this is may not only improve the ischemic syndrome, but will minimize the hemodilution during the surgery, which is essential. Low preoperative hematocrit may increase the operative mortality following CABG, often because association with other adverse risk factors. Mortality, and it's not known whether transfusion can reduce that risk or not. So hemodilution and on cardiopulmonary bypass to hematocrit below 20% may be associated with an increased risk factor of renal dysfunction, stroke, optic neuropathy, and death. Low hematocrit, lower than oncotic pressure and viscosity, which increase the fluid requirement and contribute the extracellular edema that makes more difficult to maintain adequate blood pressure during or after cardiopulmonary bypass. So patients with a profound anemia tend to bleed and require more blood component transfusion. Thus, the preoperative transfusion to an adequate level may consider to reduce patient morbidity, possibly reduce the overall number of transfusion required intra or post-operative, and potentially decrease mortality. The recommendation for the preoperative component, preoperative fibrinogen level may be considered to identify the patient at high risk of bleeding. This is class 2B level C. Routine use of viscoelastic and platelet function testing is not recommended to predict bleeding in patients without antithrombotic treatment. So it's not regularly based, although this is class 3 level C. The platelet function testing may be considered guided decision and timing of cardiac surgery patients who have recently received P2Y12 inhibitors or who have ongoing dual antiplatelet. This is class 2B level B. So something to be aware and worth to mention is herbal supplements and complementary medicine. Herbs such as thyme, rosemary, and been shown to have direct inhibitory effects on platelets. Also fish oil, omega-3, polyunsaturated fatty acid may affect platelet aggregation or vitamin K dependent coagulation factor. Omega-3 fatty acid may lower the thromboxane A2 within the platelet, as well as decrease the factor 7 levels, while garlic, ginger, and gynecobipolar have all been associated with the platelet dysfunction-induced bleeding, especially like fish oil and protein, for example. So it's giving a similar effect. Therefore, the prudent to inquire about any supplements patient may be taking prior to cardiac surgery. It's our practice to have patients stop all such remedies 7 days prior to the surgery. This is stated in Lawrence. Just as an review, this schedule found also in Lawrence for antiplatelet agent and the anticoagulation. Just to sum up and to know the mechanism of each and the binding reversibility and the half-life of each medication, so we can know when to stop them and when we can carry on with the risk. just for the future reference, can review it later. This chart or algorithm for patients with aspirin versus the dual antiplatelet. If patients came with aspirin, we need to find out, is it emergent surgery? We can proceed immediately. If it's urgent or elective surgery, it depends on. If it's high risk bleeding or refuses blood transfusion, we need to stop aspirin at least 5 days before the surgery. If it's normal or low bleeding risk, we can carry on. This is for aspirin. For dual antiplatelet, again, if it's emergent surgery, we'll proceed. If it's urgent surgery, we're gonna stop the B2Y12 inhibitors before the surgery. More than or equal days for ticagrelor, more than or equal 5 days for clopidogrel, more than or equal 7 days for prosigrel. Aspirin continue, as we mentioned before. Consider bridging with the cangrelor or GB2B3A blockers in high thromboembolic risk patients. For elective surgery, delay surgery or stop the B2Y12 inhibitors before the surgery. Again, the same. If it's more than 3 days, Tica, 5 clopidogrel, 7 days prosigrel, and aspirin to continue. This chart again I found in the same European Association guidelines. So the recommendation for the antiplatelets prior to surgery, in patient undergoing CABG, aspirin should be continued through the preoperative period. This is class 2A, level C. In patients at high risk of bleeding or refusing blood transfusion and undergoing non-coronary cardiac surgery, stopping aspirin should be considered at least 5 days preoperatively. This is class 2A, level C, as we mentioned before in the chart. It's recommended that aspirin to be restarted as soon as postoperatively. This is class 1, level B. In patients taking antiplatelet who need surgery, postponing surgery for at least 3 days after discontinuation of Tica or 5 days after discontinuing of clopidogrel and 7 days after prosigrel, as we mentioned in the chart. This is class 2A, level B. It's recommended that the GB2B3A inhibitors be discontinued at least 4 hours before surgery. This is class 1, level C. To reduce the risk bleeding, preoperative bridging of oral anticoagulation with unfractionated heparin or low molecular heparin is only indicated in patients at high risk of thrombotic events. This is also class A, but level B. Is recommended that the prophylactic low molecular heparin to be discontinued at least 12 hours before surgery, and for the Fondabronics is 24 hours before surgery. A longer interval may be necessary for patients with impaired renal function and therapeutic doses. And this is class 1, level B. It's recommended that for oral anticoagulant to be bridged with the unfractionated heparin. This is class 1, level B. Bridging oral anticoagulant with subcutaneous low molecular heparin should be considered for an alternative to bridging with the unfractionated heparin. This is class 2A, level B. Elective cardiac surgery should be performed if the INR is less than 1.5 in patients taking vitamin K. When coagulation factors should be used to reverse the effect. This is class 2A, level C. In patients having elective cardiac surgery, dual antiplatelet should be stopped at least 48 hours before surgery. A longer interval may be necessary for patients with impaired renal function. This is class 2A, level C. For the preoperative anemia, oral intravenous iron prior to the cardiac surgery, considered mildly anemic patients, which their hemoglobin for women is 10 to 12 or men 10 to 13, or in severely anemic patients, both genders less than 10. This is improve the erythropoiesis. This is class 2B level C. Erythropoietin with iron supplementation should be considered to reduce post-operative transfusion. Patient with iron deficiency, for example, erythropoietin, vitamin D, or folate acid deficiency because of their metabolism, undergoing elective surgery. This is class 2A level B. Preoperative erythrocyte transfusion is not routinely recommended in preoperative anemic patients to prevent post-operative AKI. This is class 3 level C. So for the preoperative autologous blood donation, there is, which is abbreviated as PABD, remains an option that's selected for some centers to minimize the exposure for allogenic blood, especially when there is rise of HIV that increase the interest of this preoperative autologous blood donation. The way to reduce the allogenic transfusion. Unfortunately, the acuity of most cardiac operation preclude the routine use of autologous blood donation, and there must be sufficient time between donation and surgery to allow the regeneration for the patient RBC's mass. In general, this time is minimum of 2 weeks per unit of blood donated. What is more, the patient must have enough reserve to tolerate the ensuing transient anemia, further limiting the blood autologous, the preoperative autologous blood transfusion utility. It is only option for elective, stable, preoperative patients, so it's not for everyone. What can contraindicate the blood autologous donation is the left main disease, critical aortic stenosis, congestive heart failure, severe coronary artery disease with ongoing ischemia, active endocarditis, and baseline anemia. So the recent STS and STA guidelines do not directly endorse the PABD. They mention it's only for context of the EPO, the erythropoietin use, where the guidelines state the erythropoietin additionally may consider to restore the RBC's volume in patients undergoing even the blood autologous blood donation, as we mentioned previously in the guideline. So for the cardiopulmonary bypass recommendation guidelines, actually I sum up the guidelines as it goes with the topics in the Lawrence. So for the cardiopulmonary bypass, the implantation of institutional measures to reduce the hemodilution by fluid transfusion and cardiopulmonary bypass during the cardiac surgery to reduce the risk of bleeding and the need for transfusion is recommended. This is class 1 level C. The use of closed extracorporeal circuit may be considered to reduce bleeding and transfusion. This is class 2B, level B as well. The use of bicompatible coating to reduce the preoperative bleeding and the transfusion may be considered. This is class 2B, level B. The routine use of cell salvage should be considered to prevent transfusion. This is class 2A, level B. Modified ultrafiltration may be considered as a part of blood conservation strategy to minimize the hemodilution. Can be used. This is class 2B, level B. Retrograde and antegrade autologous priming should be considered as a part of blood conservation strategy to reduce transfusion. This is class 2A, level A. normothermia during cardiopulmonary bypass in temperature more than 36 Celsius degree and maintenance of normal pH may contribute to reduce the risk of postoperative bleeding. This is class 2B, level B. So also for the planning the surgery in blood transfusion for the cardiac surgery patient, it's recommended that the members of the multidisciplinary team discuss the optimal surgical strategy based on the clinical status, comorbidities, bleeding risk, and team expertise. This is class 1, level C. Off-pump CABG surgery may be considered in selected patients to reduce the perioperative transfusion. This is class 2B, level B. Minimal invasive or minimal invasive circuits system should be considered to overstand the conventional cardiopulmonary bypass system to reduce the perioperative transfusion. This is class 2A, level B. The minimally invasive heart valve surgery may be considered to reduce the blood loss and the need of transfusion. This is class 2B, level B. Routine use of topical sealants in cardiac surgery is not recommended. This is class 3, level B. Topical sealants may be considered in clinical situations where conventional approaches to surgical and medical improvement of hemostasis, where is the bleeding problem more local than generalized. This is class 2B and level C. So for the antioperative anticoagulation, heparin level guided heparin management should be considered over ACT guided heparin. This is class 2A, level B. Heparin level guided protamine dosing may be considered to reduce bleeding and transfusion. This is class 2B, level B. Protamine should be administered in the protamine to heparin dosing ratio, which is less than 1/1 to reduce the bleeding. This is class 2A, level B. Supplementation is indicated that the patient with activated clotting time deficiency to improve the heparin sensitivity. This is class 1, level B. The antithrombin supplements is not recommended to reduce the bleeding following cardiopulmonary bypass. This is class 3, level C. In patients with HIT antibodies for whom surgery cannot be postponed for any reason, anticoagulation with biliverdin should be considered when the bleeding risk is acceptable. The use of heparin in the pre and post period should be avoided. This is class 2A, level C. For intravascular volume, the recommendation to use the goal-directed hemodynamics therapy to reduce transfusion is not recommended. This is class 3, level C. The use of modern low molecular weight starches in priming and non-priming solution to reduce bleeding and to transfusion are not recommended as well. This is also a weak evidence, is class 3, level B. Limitation of hemodilution is recommended as a part of blood conservation strategy to reduce bleeding and transfusion. This is strong evidence, class A1, level B. Preoperative autologous blood donation in patients with high hemoglobin level more than 10 or more than 110 gram per liter may be considered to reduce postoperative transfusion. This is class 2B, level B. Acute normovolumic hemodilution may be considered to reduce postoperative transfusion. This is class 2B, level B. So for the hemostatic agents, this is again a schedule just to summarize the common hemostatic agent, the Sergicel, their composition, their trend name, and the agent name. as well as the class recommendation for each. So for example, for the Surgicel is class 2B. For the Colgel or the microfiber collagen is again class 2B. So actually almost all of them are class 2B, except for the trisilor or transamic acid is class 2A. Okay. Having said that, the procoagulant interventions for the hemostatic agent, the antifibrinolytic therapy like transamic acid, aprocitenine, or epsilon aminocarburic acid to reduce bleeding and transfusion of blood products and reoperation of bleeding is class A level A, class 1 level A. So it's highly recommended. The prophylactic use of FFP to reduce the bleeding is not recommended. This is class 3 level B. The use of PCC or FFP may be considered to reverse the action of vitamin K. This is class 2B level B. In patient with factor 13, activity less than 70% after cardiopulmonary bypass, the administration of factor 13 may be considered to reduce bleeding. This is class 2B level B. Prophylactic fibrinogen administration is not recommended. This is class 3 level B. In bleeding patient with low fibrinogen level less than 1.5 gram per liter, fibrinogen submission may be considered to reduce post-operative bleeding and transfusion. This is class 2B level B. In patient where bleeding is related to coagulation factor deficiency, PCC or FFP, administration should be considered to reduce the bleeding and transfusion. This is class 2A level B. The prophylactic use of the desmopressin is to reduce the bleeding is not recommended. This is class 3 level B. In bleeding patient with the platelet dysfunction on the basis of an inherited acquired bleeding disorder, the use of desmopressin should be considered to reduce the bleeding. This is class 2A level C. The prophylactic use of recombinant factor 7 to prevent bleeding is not recommended. This is class 3 level B. In patient with refractory non-surgical bleeding, off-label use of recombinant factor 7 may be considered to reduce bleeding. This is class 2B level B. So, as a summary for the pre-intra post-operative algorithm for patients who need blood transfusion, in the pre-operative stage, identification of patients within the high risk of bleeding is important. For example, patients who have iron deficiency anemia, which is commonly found in patients with cardiac surgery. So you will give oral or IV iron to improve the erythropoiesis. Non-iron deficiency anemia, for example, vitamin D, folate deficiency, you will give EPO plus minus iron. Fibrinogen level testing, platelet function testing, all of that are important pre-operative. Intraoperatively, for maintenance of hemostasis, what you can do, meticulous surgical hemostasis, minimizing the hemodilution, for example, by many circuits or a retrograde or antegrade autologous priming, as we mentioned in the guidelines. Individual heparin and protamine titration should be really considered and measured instead of giving excessive heparin or protamine to maintain the ratio less than 1/1. The ACT, heparin, and factor 10A measurements, normothermia more than 36 Celsius and normal pH is important for patients warming, maintenance of tissue perfusion. Prevention of fibrinolysis by transamic acid, aprocitenine, and epsilon aminocarburic acids are important. and use of cell saver. So post-operative treatment of microvascular bleeding after cardiopulmonary bypass, what you can do is perioperative treatment algorithm of bleeding patients, laboratory or point of care test, insufficient fibrinogen level, less than 1.5, or low clot time, you will use fibrinogen concentrate. Coagulation factor deficiency for prolonged clotting time. You can use FFP or PCC. Low platelet count, less than 50, and or antiplatelet therapy. You can give platelet transfusion or desmopressin. Anemic patient, you will give packed Rbcs transfusion based on individual patient's condition. This chart again from the guidelines. So for the anticoagulant management during extracorporeal life support, the recommendation, the bilirubin and the argotropan may be considered for alternative of heparin for anticoagulation for prolonged ECLS or ECMO therapy to prevent the HET type 2. This is class 2B level C. Having mentioned that the point of care, just to give the explanation and to elaborate more about point of care testing include one, the targeting of transfusion therapies according to specific coagulation abnormalities. Two, rapid identification of patients who could benefit from pharmacology therapy to decrease bleeding. Three, the identification of surgical source of excessive bleeding, setting of normal test results. That can be used of the TEC or the ROTAM to assess the whole blood coagulation, platelet function, and fibrinolytic activity has gained priority in cardiac surgery nowadays. So, in summary, what's recommended? Limitation of hemodilution, routine antifibrinolytics, transfusion backed RBCs, backed RBCs of all ages, and multidisciplinary team approach. What is moderate to be considered should be aspirin should contain continued in CABG patients, cell salvage, and should be implanted. Heparin level measurement should be considered for active clotting time, guided heparin management. Protamine to heparin dosing ratio less than 1/1, and which is not recommended at all, pre-operative erythrocyte transfusion in anemic patients, routine use of typical salients, at supplementation to reduce bleeding following cardiopulmonary bypass, prophylactic FFP, fibrinogen, desmopressin, or recombinant, it's not recommended at all. And thank you. Any question, please?
Thank you very much, Dr. Amjad. This is Dr. Huda. On your review, when you were reviewing, did you come across blood conservation strategies that are employed in hospitals?
Yes, you mean the intraoperative?
Okay. Yeah, intraoperative, preoperative blood conservation. Yes. As you are all aware, we consider blood as a drug. And yes. As cardiac surgeon, you know, we don't want to do, the important thing is not to do harm to the patients. And this was very obvious in your talk. So what was the strategies that were employed from your reading? As a summary, I know you've included them, but I want you to list them if possible.
You mean that so for it's different stages, but
sure.
In the sorry.
Sure.
Yeah. So in the intraoperative, as I mentioned, like the intergrade, the retrograde using of cardiopulmonary bypass.
Mm-hmm.
Post-operatively, we can use that hemostatic agent, less use of transfusion in patients who does need all of this, that we can sum up. I'm answering your question, or?
No. Because you already mentioned it's all there. I'll just give you the information. You were saying we call it blood conservation strategies. And you've said that patients who are anemic at the beginning, so you divide it into pre-op and intra-op, right? So you said anemic patient will require blood transfusions, huh? This is what your talk was mainly talking about, right? The risk of transfusion is higher in anemic patients, right? Okay. So one of the conservation, we call it conservation therapy, is that anemic patient, if the surgery allows, and it's an elective thing, you can give them iron. Although we're talking about the recommendations, but this is disregarding the recommendations. So you can give iron supplementation. You already mentioned all these things. I've seen it, but I just wanted to be summarized because your talk is very long. And I just wanted to give an information, but it's all there. You gave us all this information. So iron supplementation can be given to these patients if the type of procedure they're going to have is going to be an elective. So you've mentioned that. So the important thing is we want to avoid blood transfusion. So we call it blood conservation. The other one is, as you stated earlier, is autologous transfusion. And the autologous transfusion are two types. One of them, you can give erythropoietin for these patients, and they can have their blood taken in the blood bank, and they will have it like twice. They can come back every 6 weeks, depending, and then they can use their own blood. The other one is the intraoperatively. Once the patient is anesthetized, the important thing that their hemoglobin has to be more than 13 to 14. And you can take, the anesthetist will take a whole blood, which includes platelets, before you give heparin, before the bypass. This is another way that you can conserve blood. You don't have to give bank blood to the patient. So that's one way. The other one you've also mentioned is using the mini bypass. And that's the main important thing is why. Why do you want to use a mini bypass from your reading, Dr. Amjad?
For ultrafiltration and...
Mini bypass, no, the ultrafiltration is another strategy. But mini bypass, if you want to reduce, you already said it, hemodilution.
The hemodilution, yes.
Exactly, perfect. So hemodilution, we want to avoid it. We don't use mini circuit for us because mini circuit, the important thing is it doesn't have a venous reservoir. But what we use is that the lining, we reduce it, we make it smaller. The other one you said, the retrograde priming. That's one way also to reduce the hemodilution. The use of cell saver is very important also. And usually for us, we use it for financial issue. We use it for redos. Actually, we don't use it in every case. There are centers that use it for every case. The other one you've already mentioned is using antifibrinolytic agents. This is used, is a strategy. Mainly our anesthetists, they use the tranexamic acid. I think it's used in most of the centers. So in every level, you have to think about, we don't want to give blood to this patient because we know blood increases, as you stated in your talk, morbidity and mortality, right?
Yes.
Okay, so this strategy is called blood conservation strategy. So you have to make a summary of all these information, and that means when we ask you about blood conservation. The other thing is the triggers for transfusion. Just to make it very simple, below 7 with hemodynamic instability, because it's important that the patient must have some hemodynamic stuff. You don't give blood just for the heck of it, for the hemoglobin, for a number. So if the patient hemodynamically unstable, you give blood transfusion. 10 you do not give. Okay, we're talking about the level. We're not talking about that. And in between 7 and 10, it depends on the clinical situation. So just to make it simple. Below 7, you transfuse. 10, you do not. But it depends, of course, on the clinical situation. And 7 to 10, it's a clinical judgment. So just to make it easier, this is the important thing I just needed to talk about. Just to summarize from your lecture, what is important as cardiac surgeons. Factor 7, you were talking about factor 7. We do not use factor 7 liberally, as you mentioned, because it can cause thrombosis. There are valves that got thrombosed, there are grafts that got thrombosed, but it's not very common. But we use it in patients who other methodologies, other therapies have failed. Sometimes only factor 7 can stop the bleeding. And we're talking about medical bleeding, because if you have bleeding, you make sure it's not a surgical bleed first. That's one thing. And I think that's about it. I can add, but thank you very much. You have done an extensive review, and I thank you very much for doing this.
Thank you, Dr. Thank you.
Okay. Anyone else have anything to add to ask Dr. Amjad?
Actually, Dr. Huda, we always have a debate regarding transfusing or not.
Sure.
And some of the doctors, they transfuse only for numbers.
Sure.
And I disagree with this. I always, when they ask me, I always tell them that you have to clinically see the patient and see the vitals,
sure.
and then correlate with the number. So we always have a debate with this. Always people disagree, and some they will agree, and so on.
If you have a patient with renal failure, they will always be anemic. They will have hemoglobin of 6, huh?
Yes.
You don't transfuse that patient if hemodynamically stable, of course.
Mm-hmm.
But if you have a young guy who is fit and tells you that I have dizziness and his hemoglobin is 6 or 7, and you've ruled out any other problems, it doesn't have ongoing, you transfuse them, because the important thing is the oxygen carrying capacity, right? As Dr. Amjad stated earlier, 7
exactly.
is the number. 7 is the number. Below 7, your oxygen carrying capacity is low. So that's there would be a difference between the demand and the consumption. Okay?
Yes, yes.
So you are correct. You have to correlate it with the clinical situation and of the patient itself.
Mm-hmm.
Okay?
Okay.
The other thing to also ask, the aprocinin, it is not used in our country at all. It was stopped a long time ago because there was a publication, I think you all know about it, with a renal impairment. So we do not use aprocinin. Whatever you read in the guidelines, it's not used in Saudi Arabia.
Yes.
Okay. Any other questions or comments before we end?
Doctora?
Aywa?
I have just one question regarding the threshold for transfusion.
Yes.
Is 7 a universal threshold, like for certain patients, like patients with hypertrophic myocardium?
Sure.
Should we have a higher threshold, or we use the same threshold as all other patients?
You use the same, as I said, it's hemodynamic effect, like your patient is hemodynamically unstable. Right now we're talking about usually blood transfusion is given for bleeding. For us, it's not medical, we are not cardiology. I'm not talking in the ward, we're talking about post-operative. That's the one you're talking about, or you want to talk about when the patient is in the ward. What are you talking about? Which one?
I
it's different.
Yeah, when the patient is, let's say he's a post-CABG patient and now he was transfused to the floor, and for some reason his hemoglobin is 8. Do you think we should follow the same threshold, or we should have a higher threshold?
No, it doesn't affect. No, there's nothing. It does not affect, provided, as I said, it's hemodynamically, clinically, like patient for you, blood pressure is low, he's tachycardic, patient is complaining of dizziness, hypotension, It has to be clear, because as I said, if you consider blood as a drug, then you will not be liberally given it. So it's not a number. And as I stated, below 7, that's affect the hemodynamics. It can cause ischemia, so some patients. But between 7 and 10, it's a clinical judgment. So when you say 8, that's a clinical judgment. Got it?
Okay. Yes, clear, Doctor. Thank you.
Aywa. Below 7, yes, the point you are concerned about regarding the perfusion, as I said, the difference between consumption and demand and supply, it's 7 is the trigger number. Some people say 7.5, but 7, just to make it easier. Okay?
Yes, thank you, Dr.
Yeah, you're welcome. Okay, thank you very much, everybody. It's been a pleasure. And hope to hear from you soon, inshallah. And have a nice weekend.
Thank you, Dr. Hoda, for joining us today.
Okay.
Thank you, Amjad, and see you next week, inshallah.
Inshallah.